this year's CME is on respiratory critical care. We are starting from basics, Airway to ECMO. So we welcome you all again, and I request our CEO, Mr. Dr. Shilpi Mani, to do the welcome address. So,
good evening, all. On behalf of SKS Hospital and Postgraduate Medical Institute, I welcome all the speakers and participants for the SAP 2023 second edition. This is SKS Intensive Care Program. And I'm happy to declare that from today, our hospital is full level NABH accredited hospital. To talk about our hospital, we are DNB approved hospital for medicine, pediatrics, anesthesia, OG, ortho, radiology, and F&B spine. We also adding 2 more departments this year, that is DNB critical care and surgery. We are awaiting for the final approval. I'll hand over the session to Dr. Nishan.
Yes. Okay, sir. So as you're all aware of it, today's today's session will be securing the airway. The first talk is on how to go about in securing the airway in ICU and ER. Okay. So I invite Dr. M. Satyaprakash sir. He is our consultant HOD of anesthesia and critical care in SKS Hospital Postgraduate Medical Institute, and he has vast experience in anesthesia, and he has done his MBBS from Sri Ramachandra Medical College, and DA from Raja Muttaya, and his DNB from Satya Sai Institute, Karnataka, and he finished his fellowship in pain medicine from Daradia Pain Clinic, Kolkata, and his area of interest are critical care and difficult airway, and he has many ongoing research in his department under his postgraduates. I hand over session to Dr. Satyaprakash sir. For just again, I wanted to convey this. This should be an interactive session. All 4 or 5 speeches, whatever you are going to speak today, please feel free to ask questions. Maybe there will be a separate time for discussion at the end of each talk. Feel free to ask questions, and if any difficulties in hearing our audio or video, please do let us know. You have our numbers, my number and Mr. Sababadi number. Please let us know, and also you can put any queries in the chat box, which will be responded immediately. Please do let us know if you have any difficulties in hearing us or listening to the CME. Thank you, Honado. I hand over the session to Dr. Satyaprakash sir.
Good evening, everybody. Very happy to welcome you all to this online CME. And today's the first topic of our presentation is preparation for emergency intubation in the intensive care unit and the emergency room. So I shall try to make it very simple and clear, and I'll stick to my timings. Please stay with me for the next few minutes. Thank you. So our agenda for today's presentation will be done in the following order. Like why this topic was selected, and why securing an airway in the intensive care unit or in the casualty is difficult when compared to an operating theatre. So we are going to discuss the plans for a successful airway management and regarding the OTEX algorithm, and don't fall deep into the vortex. So why this topic? So airway management is a fundamental aspect of emergency and critical care medicine. And expertise in airway management is a very important skill. An experienced emergency medical service provider will tell us that when treating a patient, the 3 most important considerations are airway, and airway. So why securing airway in the ICU or ER is difficult compared to that in OT? In the operating room, we have the preoperative assessment of the patients. We do the pre-op assessment of the patients the previous day, and we know the comorbidities of the patient. We know the patient, what kind of problem he has, and we devise a plan accordingly, a specific plan, a specific type of anesthesia, and we, in case of anticipated difficult airway, we are already ready to face it. Whereas in the emergency room, it's not possible because all the patients are new to us, and we don't have much time to elicit all the history, almost all our emergency indications, and they are with hemodynamically unstable also, the deranged physiology. So there are many factors related to this difficulty. It could be factors related to the healthcare personnel, patient-related factors, logistics or environment related, and it is multifactorial. So now let me come to the indications of emergency intubations. I'm sure every one of you are familiar with this. So I'll just go through as fast as possible. So loss of airway protection when the BCS is less than 8, there is loss of gag and cough reflex, airway obstruction in case of edema, anticipated loss of airway control in case of worsening stridor and burns, and failure of ventilation when the PaO2 is less, PCO2 is more than 50 millimeters of mercury, neurological problems like sedation, narcosis, brain or spinal cord injury. You have peripheral nerve diseases, example, Guillain-Barré syndrome, muscular problems like steroid-induced myopathy and myasthenia gravis, anatomical problems in case of rib fracture, pneumothorax, or intra-abdominal hypertension, gas exchange problems in case of acute lung injury or lung conditions, and diffusion abnormalities like pulmonary edema, aspiration, and even pulmonary alveolar proteinosis, increased dead space in case of pulmonary embolus, and shunt with airway collapse, pneumonia, and acute lung injury. So conditions related to the healthcare personnel, like the lack of patient preparation and failure to check the equipments when you attend your duties, and when your decision making is poor, and any deviation from the local protocols or failure to follow the proper protocols, and loss of situational awareness or loss of sense of time by the intubator, and lack of senior help in case of out of hour intubations, and poor team efforts. In case of patient-related factors, you may have a physiologically unstable patients or anatomically difficult airways in case of trauma, in case of cervical spine injury or burns. An increased risk of aspiration when the airway assessment is difficult, and poor cooperation from the patients with low GCS, column marks, and limited time. So now we come to the Makocha scoring. So this is to assess the airway in case of emergency patients. So we have a total score of 12, in which 0 comes for easy intubation, and the score of 12, it makes it very difficult intubations. So what are the patient-related factors? Malapati score of 3 or 4, obstructive sleep apnea syndrome, reduced cervical spine mobility, limited mouth opening less than 3 centimeters, and Glasgow Coma score less than 8, severe hypoxemia, and non-anesthesiologist. So this Makocha scoring still holds good for assessing an airway in emergency patients. And other predictors of difficult airway that predict hard to ventilate with the Boot score of BERD, obstructive sleep apnea syndrome, old, edentulous, and with stridor, and predict hard to intubate with the Lemon score, with look externally for any facial dysmorphism, and with BERD or with beards, and any facial abnormalities due to trauma, and evaluate the 3-3-2 rule, the 3 finger breadths for mouth opening, 3 finger breadths between the mentohair distance, and 2 finger breadths between the floor of mouth and the hair bone. Then the Malapati score in case of any obstructive symptoms and neck movements. With regard to the dentures should be in for bag and valve mask ventilation, and the dentures should be out in case of intubations. Coming to the logistics or environment related factors, like limited access to the patient monitors or the patient equipments. And when the monitors are on the head end of the patient, we are also standing on the head and difficult to have a look at the monitors. And when the lighting is suboptimal, and decreased access to advanced airway devices or non-availability of capnography, cognitive overload and poor decision making, and non-availability of the surgical staff. So any plan for successful airway management should have these 6 important things like preparation of the patient, preparation of the equipments, preparation of the staff, so the healthcare personnel, and preparation of the environment, and then preparing ourselves for the process 2. And assessment. Assessment starts with the preoperative, pre-assessment of the patient in the emergency room, and assessment of the airway, and positioning the patient, and pre-oxygenation of the patient, that we will discuss later. Then comes to the process of intubation, and then the stabilization process after the intubations. So this is the Intensive Care Society intubation checklist for the critically ill patients devised by the RCOA guidelines. So I'll just go through this one by one in detail. So first thing is preparing the patient. The first thing to have is a reliable intravenous or intraosseous access, preferably with an 18 gauge cannula. Then optimize the position of the patient, either sit up or semi-recumbent if it's possible, And in case of any alphabet, deflate the alphabet and make the mattress hard for us to keep it simple for intubations. And airway assessment, like identify the cricothyroid membrane, and is there any option for awake intubation in case of any cervical cord injury or difficult airway? And optimal pre-oxygenation for 3 minutes with 100% FiO2. Consider continuous positive airway pressure with non-invasive ventilations, or high flow nasal oxygen, or a simple nasal O2 with 15 liters of O2 per minute. Optimizing the patient's hemodynamics either with fluids, vasopressors, inotropes, and in case of nasogastric tube, aspiration should be done. And then the delayed sequence induction. What is delayed sequence induction? It is the breaking the sequence of paralytic and the sedatives to let alone give time for more pre-oxygenations, like administering specific sedative agents like ketamine, so that it doesn't blunt the spontaneous ventilations. And in case of allergies, where there is increased potassium risk, like in burns or any cervical cord injury or a neuronal debilitation, where there is increased potassium risk, where there is proliferation of the extrajunctional receptors, we tend to avoid saxamethonin. In those cases, we can go ahead with roquenorone. Then preparing the equipment, like basic equipments, we have like NIBP, ECG, ETCO2, and saturation, SpO2. Checking the equipments with adequate endotracheal tubes, laryngoscopy, either the conventional laryngoscopy or the video laryngoscopy if it is available, gum elastic bougie and stirrups, working suction, supraglottic airways, preferably the second generation supraglottic airways like Hygen, Supreme LMA, ProSeal, or the intubating LMA. You have Gudel's oral and nasopharyngeal airways to be available, flexible scopy, ambuscopy, and front of neck airway access set, either the conventional scalpel cricothyrotomy or the cricothyrotomy set if we have it. And checking for drugs, either ketamine, etomidate, or propofol, and relaxants like depolarizing or non-depolarizing relaxants kept available. Adequate vasopressors and inotropes properly loaded and kept in the syringe pumps, and maintenance sedation, and adequate analgesics also. Preparing the team, it is always better to allocate the roles. And in case of any difficult airway, it is better to alert the senior persons in case of out of our intubations. There should be a team leader, first intubator, second intubator if available, a required force provider, the intubator's assistant, the drug keeper, the person who's going to administer the drugs, monitoring the patients, and mills. What is mills? Like manual inline neck stabilization in case of suspected cervical spinal cord injury. And who is going to perform the front of neck airway access? Like whoever is available, we can give a call to them. So whom do we call for help? So everything should be properly prepared and allocated. The role should be properly allocated. The time, noting the time is also very important, because the intubator who is involved in the process of intubation is totally, there will be a lack of situational awareness. There is no sense of time. So somebody should be noting the time and informing them. In preparing for difficulty, so always verbalize what's going to be our airway plan. Plan A, as we all know, is going to be laryngoscopy, either with the conventional laryngoscopy or video laryngoscopy, with 3 attempts, 3 plus 1 attempts at each. And if not, we're going to go ahead with a plan B, that is second generation supraglottic airway. And if you're able to oxygenate, well and good. And if not, we are going to the face mask oxygenation using adequate airway agents with nasopharyngeal airway or oral airways, proper chin lift and jaw thrust. And if you are not able to succeed with it, you can even consider some neuromuscular blockade. And then if we are not able to oxygenate even with the face mask, that is the plan C, then we go to the plan D, that is front of neck airway access, the scalpel bougie tube technique. That is scalpel cricothyrotomy, then turning the scalpel quarterly, then introducing a bougie, then a 6 millimeter internal diameter tube for a scalpel cricothyrotomy. And 2 things need special mention. One is the positioning. The next thing will be the pre-oxygenations. So as we all know, the positioning of the patient in such a way so as to bring the oral pharyngeal and laryngeal axis in the same plane, and keeping a pillow under the occiput, like extension of the neck and flexion at the atlantoaxial joint. So brings all 3 axes in the same line. And in case of obese individuals, we go ahead with the ramp position. That is the where the suprasternal notch and the external auditory meatus are in the same plane. That can be achieved keeping a pillow like this. I just follow, and this is the ramp for these individuals. Yeah. to the pre-oxygenations. So tracheal intubations in the intensive care unit or in the emergency room have got very life-threatening, can be encountered with severe life-threatening complications like arrhythmias, severe hypoxemia, and even cardiac arrest and death. So pre-oxygenation is a process of stocking the lungs with a sufficient amount of oxygen. So pre-oxygenation is always mandatory, apart from doing it in the operating room before induction. So pre-oxygenation is mandatory in the intensive care unit and emergency room also. But how are we going to do it? And let's say into it, one technique does not fit all. A multi-centric retrospective trial showed a 2.7% rise in cardiac arrest due to hypoxemia and lack of pre-oxygenation, leading to increased 28-day mortality. And there were many trials like this MACMAN trial, Florari 2 study, and the Optinov trial study, which all compared between the high flow nasal oxygen, non-invasive ventilation with CPAP of 5 to 10 centimeters of pressure support, and which all showed like this non-invasive ventilation reduced the incidence of hypoxemia in almost 300 patients in whom the PaO2 and FiO2 ratio was less than 200 millimeters of mercury. And so this is a protocol that was suggested. Still, there are studies ongoing to get an adequate protocol for the pre-oxygenation in the emergency room. In case of mild ARDS, like where the PaO2 FiO2 ratio is less than 200, 300 millimeters of mercury, they use the face mask or a nasal cannula with 15 liters of O2 or a bag and mask while oxygenation in case there is a SpO2 drop below 90%. In case of moderate with 100 to 200 millimeters of mercury, they use CPAP mask with a peak of 5 to 10 centimeters of water with FiO2 of 100%. And after induction and during laryngoscopy, they use the high flow nasal oxygen with 60 liters of oxygen per minute for apneic oxygenations. And in case they encountered an SpO2 fall of less than 90%, they used bag and mask ventilations. In case of severe ARDS, less than 100 millimeters of mercury PaO2 FiO2 ratio, they use non-invasive ventilation, and they even considered an awake fiber optic intubation through dedicated NAV mask. And in case the saturation falls below 90%, they proceeded with the bag and mask ventilations. So non-invasive ventilations, especially for cases who already hypoxemic, and high flow nasal oxygen adjuncts to non-invasive ventilation patients with PaO2 FiO2 ratio less than 300 millimeters of mercury. Any patients with a PaO2 FiO2 ratio less than 100, they suggested awake fiber optic bronchoscopy without interrupting the non-invasive ventilation through dedicated mask. And this is just come back to this OTEX algorithm. So this is an emergency airway cognitive tool. So it's a very simple, novel tool, easy to learn for the clinicians who are all involved in advanced airway management. It is a funnel-shaped tool in which the outer green zone, as you can all see, is a zone of oxygenation. The inner blue zone depicts the zone where we are unable to oxygenate the patient, or the patient is going in for worsening cyanosis. And then the inner dark blue zone shows the zone of CICO, that is cannot intubate, cannot oxygenate scenario. There we are going to proceed with thing. Once you're able to oxygenate, you're coming back into the green zone. So there you have time to assess the patient to proceed with the next step of plan for the airway management. So this is a very simple tool where you're going to use 3 lifelines. The first lifeline is going to be an endotracheal tube. You're going to use a 3+1 attempts, either with a conventional laryngoscopy or a video laryngoscopy. If you're not able to oxygenate with that, or if you're not able to succeed with that, you're going into the second lifeline with a supraglottic airway. That is the second generation supraglottic airway. And if you're able to oxygenate, you come into the green zone. But if you fail to do it, you go back into the third lifeline with the face mask using proper adjuncts and differing the sizes. If you're able to oxygenate, you have time for it. And if you're not able to do it, consider a neuromuscular blockade. Even then, you're not able to do it. You go into the blue zone where you have to go for a CICO, announced CICO. Then you go for scalpel cricothyrotomy or a front of neck airway access. So now they have planned to incorporate this vortex. They have already incorporated this vortex algorithm into the DAS guidelines for the Difficult Airway Society. So this slide, I'll just come back to the end. So 10 commandments for airway control. So airway management does not mean intubation alone. It is the oxygenation and ventilation. Oxygenation is the top priority of the patient. So using proper adjuncts, properly, if you're able to ventilate the patient, if you're able to oxygenate the patient, is well and good. So oxygenation and ventilation are the top priorities. And be an expert at bag and valve mask ventilations. So everybody who are all involved in advanced airway management should be an expert at this bag valve mask ventilations using proper adjuncts, proper oral airways, jaw thrust, chin lift, and nasopharyngeal airways. You should be an expert at this bag and valve mask ventilations. So preparedness is the key to success. Always preparing the patient, preparing the proper equipments, preparing the environment, and preparing your staffs is always the key to success. So we have to know at least one rescue ventilation technique. So let it be a supraglottic airway, let it be a laryngeal tube, a combi tube, or intubating LMA, so whatever it is, and even the scalpel cricothyroidotomy. So always try to develop your own personal airway algorithm according to your skills and according to your specific resources available at your center. So it is always helpful at the time of this unanticipated difficult airways. And don't let your pride or ego get in the way. If you're not able to succeed, always you call for the other persons. Call for help, call for help, call for help always. And use capnography or esophageal detector device to confirm every intubation. Apart from our visualizing the ET tube getting inside the glottis, your fogging of the ET tube, the chest rise, but using a capnography or the esophageal detector device is always the gold standard. So when seconds count, don't count on seconds. Like what I'm trying to say is, so each one of the attempts on the airway should be our best efforts. So whatever airway adjuncts we have, we should try to use it, and each effort should be our best effort to oxygenate and ventilate the patient and then to secure the airway. So practicing airway management skills, it is always very important. Keep on updating yourself, keep practicing the airway management skills. So that is very, very, very important. Thank you. So the session is open for questions.
Thanks for wonderful talk, sir. And going to the questions, Dr. Muthukumar asked a question, sir. Will neuromuscular blockade be given if we can't mask ventilate?
Yes, sir. There is an option of even the criteria says if you are not able in plan C, if you're not able to mask ventilate the patient, you can try with the short acting depolarizing blockade. Even in the criteria, there is a thing for neuromuscular blockade.
Okay.
And even now, if you have this rocuronium and sugammadex available, you can just try it on even in emergency situations. If there are any contraindications for scolding.
Hope that answered the question. The next question, sir. Sir, what should be the settings if we are using NIV for pre-oxygenation?
Like pressure support around 10 centimeters of water and PEEP of 5 centimeters of water with 100% FiO2.
Adding on to it, just to make sure that after you give the relaxant, the mode should be in control ventilation. If at all the patient was on CPAP, we tend to keep that continue on CPAP. So make sure that you change to pressure control ventilation because patient will not be initiating the breaths. So anything you want to add on to this, sir? As sir exactly told, don't let your pride get in the way when you manage the airway. Bag valve mask ventilation holds the key in success if you're not able to ventilate. So what to do if we don't ventilate? Before going to that, how to successfully intubate a patient, that is rapid sequence intubation. Before that, so one more question, sir. Is hyperventilating necessary with BVM?
No, like adequate tidal volumes of around, if you are able to generate around 6 ml per kg with 12 to 14 breaths per minute, that's well and good. And depending upon the patient's condition. So suppose if you have a diabetic ketoacidosis patient who is already hyperventilating, you cannot have the breaths at around 10 to 12 breaths per minute. There you have, even after securing the airway, you tend to have a higher respiratory rate around 24 to 28 for those patients. So it depends upon the patient's conditions.
Yes.
Anything you want to add to it?
That's it, sir. So that question was from iPhone. Please, I kindly request every delegate to rename yourself. Don't put like that iPhone so that we can maintain the attendance and hand over to TNMC. And one more question from Dr. Pramod Roshan. What will be the drugs of choice for patients suspecting ICH head injury? Probably that is the next talk. So modified RSI, each patient is different. We are going to that. And the final question, we will take this, sir. One more question. Have you used HFNO in difficult ventilation? From Dr. Muthukumar again.
Yes, sir. We have used it. We kept the high flow nasal oxygen flow of around 60 liters per minute with 100 with a 502. We have tried it for apneic oxygenation also. It helps a lot. Even in the operating room for a foreign body bronchoscopy, we tend to use it in pediatric patients and also in the ICU. It really helps a lot. So CPAP, NIV mask with HFNO adjuncts is very useful for pre-oxygenation inside the ICU and emergency room.
Thank you, sir. So that ends the first talk. Wonderful talk. Moving on to next talk, Dr. Shekhar, sir, starts session with the question already on board. Sir, what will be the drugs of choice for patients suspecting intracranial hemorrhage or head injury? The apt question for a neuroanesthetist managing a high volume trauma center. So I invite Dr. Shekhar, sir, a consultant anesthetist, neuroanesthetist in Neuro Foundation, Salem. So about a few words about him. He has been in active anesthesiology practice since 20 years and has been practicing for past 12 years as neuroanesthesiologist and neurointensivist at Neuro Foundation Hospital, Salem. His area of interest include neuroendoscopic surgery, cerebrovascular surgeries, neurotrauma, and intensive care management of TBIs. He graduated from our own Salem Government Mohan Kumar Amangala Medical College and completed MD from BJ Medical College, Ahmedabad. And he has many papers to his name, and especially on awake craniotomy and recent concepts in head injury management in a state conferences. Over to Dr. Shekhar, sir. So talk will be on RSI. Each patient is different. Over to you, sir. Thank you, sir.
Thank you.
Over to you, sir. Shekhar, sir.
Nishant, I'm not able to share the screen.
1 minute, sir. Sir, ipa paranga, sir.
Just a minute.
Yes.
Yeah.
Yes, sir.
Nishant,
Yes, sir. You can.
is it visible?
Yes, sir. It's visible. Your audio is very clear, sir.
Okay, thank you. Nishant, thank you for your nice introduction. First of all, I have to congratulate you and your team for initiating this kind of webinars, first of its kind in Salem. And I'm very sure that this will be useful to upgrade or update PG residents as well as the practicing physicians or intensivists and anesthesiologists. And I'd like to thank for giving me an opportunity to present this in this webinar. My topic today is the rapid sequence interventions in RSI, and each patient is different. And all of us are aware of this RSI and are practicing this RSI in our regular day-to-day practice. Before I move on to the various techniques in different scenarios, I'd like to go through a few slides on what is RSI and how is it being done. RSI is a method of achieving rapid control of airway while minimizing the risk of regurgitations and aspiration of gastric contents in patients at risk. It involves administration of an induction agent and neuromuscular blocking agents to induce unconsciousness and paralysis, to facilitate rapid tracheal intubations, to maximize the chances of successful intubation and minimize the risk of aspirations. The main thing is the maximal pre-oxygenation and physiological optimizations are essential before drug administration. RSI is not a new thing. It was originally described as far as in 1961 by Selix, and the components are: the stomach is emptied by a nasogastric tube and then removed before intubations. Patients are pre-oxygenated. Patients are positioned supine with the head down tilt, and induction agent is given on waist-based dosages, and anesthesia induced with barbiturates or volatile, and rapid-acting muscle relaxants are subsequently used, and crackhead pressure is applied, and laryngoscopy and intubation of trachea with a cuff tube immediately following fasciculations. Once intubation is confirmed, then the crackhead pressure is released and BVM ventilation is avoided. But this original technique has been modified over a period of a year, and a few points to be noted are: not an NG tube is not routinely placed, and in place of head-on tilt, a supine or ramp position is used. And the induction agent is titrated to loss of consciousness rather than weight-based dosages. And apart from thiopentone, which is used in the by Celix, other agents like propofol, ketamine, midazolam, or etomidate are used. And in addition to succinylcholine, rocuronium is used as a NMBA, and crackhead pressure is optional, and many consultants they omit crackhead pressure, and if needed, BVM can be with ventilation can be used to the BVM with a pressure of less than 20 centimeter of water. And the indications are general indications like patients with a full stomach and any patients undergoing emergency surgery or who has sustained trauma regardless of the interval since loss of oral intake, who are not fasted according to the preoperative fasting guidelines, and patients with gastrointestinal pathology like gastroparesis, small bowel obstruction, gastric obstructions, esophageal stricture, and GERD. On patients with increased intraabdominal pressure like morbid obesity, ascites, and pregnancy after 20 weeks of gestations. Contraindications, there are very few contraindications. The absolute one are when there is a total upper airway obstructions and total loss of facial or oropharyngeal landmarks. The relative contraindications are anticipation of a difficult airway, or when there is a rescue oxygenation is impossible, or who cannot tolerate apnea like patients with refractory hypoxemia or severe metabolic acidosis. What are the steps of RSI? There are 7 P's. It starts with preparation, ends with post-intubation management. Preparation should be done 10 minutes before intubations, and pre-oxygenations 5 minutes before intubations. And patient should be optimized physiologically, which is 3 minutes before intubations, maybe longer if depending on the necessary interventions and time available. And patient is paralyzed with induction, and patient is positioned and protected with the crackhead pressures if possible, if needed, 30 seconds after induction. And patient intubated and confirmed after 45 seconds of induction. Post-intubation management 60 seconds after induction. A proper preparation prevents poor performance. What the goal is to maximize the chances for successful intubations on the first attempts without adverse events like hypoxemia, hypotension, or esophageal intubations, because the number of attempts increases the adverse events. Preparations, the basics are initially the patient's airway should be assessed anatomically and physiologically, and there should be airway management plan, including a backup strategy and assembly of all necessary personnel and equipment and medications. I'm not going into detail of how to prepare it because Dr. Satya Prakash has gone through it in detail, so I just skip the few next slides. Preparations, top mite, the mnemonic, and lemon for airway assessment, and pre-oxygenations. This point also is clearly told by Dr. Satya Prakash. Just to recap, why pre-oxygenations? So it replaces the nitrogen in the lung and creates a large oxygen reservoirs, which significantly prolongs the safe apneic time. Just few points. The expected time to desaturation is below 90% after apnea, and different patient groups. A healthy 70 kg male, it takes 6 to 8 minutes. Whereas in young children less than 20 kg, it's only less than 4 minutes. And a chronic illness or obese patients, it's less than 3 minutes. And pregnant patients near full term, it's less than 3 minutes. And critically ill patients, they decelerate even more quickly. This points to, again, re-emphasize the importance of pre-oxygenations before inductions or intubation. Various methods, again, it has been told clearly in the previous talk. And just to highlight some few points, if the patient has inadequate spontaneous ventilation, a gentle positive pressure ventilation with a bag mask at flush flow rate with a synchronous bag as technique is useful. What do you mean by flush flow rate? The knob in the flow meter should be opened beyond the point which it cannot be opened. That means more than 15 liters per minute. And in patients with adequate spontaneous ventilation and cooperative patients, NRBM mask with a flush flow rate oxygen, and adequate spontaneous ventilations but uncooperative patients, DAC or delayed sequence intubation. With what does it mean is you give a low dose of sedative agents of ketamine or fentanyl to make the patients quiet. Then you can go ahead with the other techniques. And patients with right to left intrapulmonary shunting like ARDS, pneumonia, a bag wall mask with a PEEP wall or NIV or high flow nasal oxygen systems can be used. And there are a few adjunct strategies to maximize pre-oxygenation like proper positioning, a head up tilt for 30 degree, continuous passive oxygenation during apnea, the apneic oxygenation, and giving oxygen through nasal prongs at 10 to 15 liters per minute, and gentle ventilation for patients who cannot tolerate apnea with a pressure of less than 15 centimeters of water. And airway patency can be improved using an oral or nasal airway. A lot of emphasis has been given recently on physiological abnormalities that complicates emergency airway management, which they call it as a physiologically difficult airway. The physiological derailments are hypoxemia, hypotension, and this places patients at greater risk of cardiovascular collapse during peri-intubation period. Hypoxemia, we can circumvent by doing pre-oxygenations, and hypotensions, it can be intervened in different situations by different techniques. For example, in hypovolemic shock, a bolus of isotonic fluid 20 to 30 ml given, and blood tailored to the case should be rapidly administered in case of hemorrhagic shock. And suppose the patient is persistently hypotensive despite fluid changes, like in sepsis shock, vasopressors can be used, and in cardiogenic shock patients, ionotropes like dobutamine can be used. The whole idea is you have to maintain a target MAP of 65 millimeters of mercury or till the resolution of clinical signs of poor perfusion. Premedications, the goals are to relieve anxiety or reduce volume or increase the pH of stomach contents, to blend or eliminate the physiology response to airway managements like increased HR or BP, bronchospasm, increased ICP, and to avoid fasciculations. And for anxieties, one can use a low dose of midazolam, and antacid, sodium citrate can be used, and H2 blockers for ranitidine and prokinetic like metoclopramide, which not only increases the LES tone, it improves the stomach emptying, and as they will be used as an antiemetic also. And premedications, a simple mnemonic is load, lignocaine, opioids, atropine, and defasciculations. Lignocaine, it blends the sympathetic response to scopy and suppresses the cough reflex. So it has been used regularly by all the anesthetists in the OT. But recent studies have shown it has no significant effect on blunting the response. And in contrary, it causes hypotension. So definitely, lignocaine should not be used for pre-treatment in patients with hypotension. Opioids, fentanyl, commonly used to blend the pressure response. And it has an additional factor like it's analgesic as well as sedation also. Atropine, it is used in a dose of 20 mg per kg, especially in patients, neonate patients and children less than 5 years. Not routinely used in adults. It helps in blunting the vagal response to scopy and when you use scoline. Defasciculations, it's not used nowadays. The patient should be induced next. The goal is to facilitate loss of consciousness in one arm brain circulation time and to avoid hemodynamic compromise. Various induction agents has been used like ketamine, etomidate, propofol with its own pluses and minuses. Propofol is commonly used in patients who are all stable, healthy, but it's a poor choice in unstable patients because it causes profound hypotensions due to vasodilation and myocardial depression, and it causes pain on injection. And ketamine, it's sympathomimetic and it augments heart rate and BP, so it's very useful in patients who are hemodynamically unstable. And it can be used in reactive airway disease because it has a bronchodilator property also. And it's in addition, it's an analgesic and anesthetic property. And etomidate is a very good agent because it's the effect on heart rate and BP is very minimal. So it can be used in patients in cardiogenic shock patients and who are unstable patients. So there are some controversies regarding its use in sepsis because various articles have shown that it inhibits the adrenal cortical productions. But there are many studies have shown that the inhibition is very minimal and it lasts only for about less than 36 hours. And it can be avoided when you co-administer corticosteroids along with this. So still, it's a good choice of for patients with the septic shock. Midazolam is not routinely used nowadays. Once patient is induced, it should be paralyzed. An ideal agent should be have a rapid onset of action to minimize the risk of aspiration and hypoxia, and it should have a rapid recovery to facilitate the return of ventilation if intubation fails. And it should have minimal hemodynamic and systemic effect. The commonly used agents are suxamethonium and rocuronium. Suxa is used in a dose of 1 to 2 milligram. It's the fastest acting neuromuscular blockade, actions in 45 to 60 seconds and reacts for about 8 to 10 minutes. But caution should be it might cause hyperkalemia, or it's dangerous in patients with hyperkalemia like burns patients, CKD patients, patients with crush injuries where the chance of hyperkalemia is more, and patients with malignant hypothermia, in which cases rocuronium can be used. Rocuronium is an excellent alternative. Normally, for anesthesia induction, you use 0.6 milligram per kg, whereas for RSA, it is used in a dose of 1.2 milligram per kg so that the onset will be in 60 to 75 minutes. And it acts for about 30 to 60 minutes. So only drawback is it's a long acting one. So what is important is, so whatever the induction agents we use, it has a short acting, and it's around 3 to 5 minutes or maximum 10 minutes. But if we use rocuronium for paralyzing, so patient will be paralyzed, but they will be aware. So patient needs to be sedated and given infusions till they come out of paralyzing effects. But nowadays, and Sugma does agents which causes reversal of neuromuscular blockade is available. So only thing is a bit costly and it's not available very freely. Recently, Nyan has started introduced the Sugma injections. So if it is available, if it can be used at a dosage of 16 milligram per kg, it can reverse neuromuscular blockade of rocuronium very fast. Next is patient should be positioned, and the various positions are described by Shati Prakash, like head and elevations, the ramp positions in obese patients. A sniffing positions is routinely used, but care should be taken in patients with cervical spine trauma or patients who are all unconscious, because we don't know whether patients will have cervical spine injury or not. Now, how we will protect the airway during this before intubations? That's basically maneuver. It's only Crackert pressures. How we do, everybody knows it, and it occludes the lumen of the esophagus and prevent regurgitations of stomach contents. A force of 10 newtons and during awake and up to 30 newtons when the patient loses consciousness, and released if intubations proves difficult and or for mask ventilations, and it is contraindicated in cervical spine injury, anterior trauma, active vomiting, and foreign body neck. There are a few controversies whether it should be used routinely or not. So why these controversies are come, why this discussion has come is various studies have shown that the application of Crackert pressures displaces the esophagus laterally in 90% of the patients, and it did not effectively compresses the esophagus. And many cases it worsened CL grade view during laryngoscopy. And even if it is applied properly, the studies have shown there's no difference in the incidence of aspirations. In fact, it reduces the lower esophageal sphincter tone and therefore it increases the reflux risk. The immediate intubation time was longer in patients who had Crackert pressure applied. So the option of Crackert pressure is optional, but still it can be used when you think there is an aspiration is high risk. So in most situations, it's not harmful and may be beneficial and can be used. And patient should be intubated with a cuff tube, and once it's confirmed, the Crackert pressure should be released. The various ways of confirmation is only is during intubations, direct visualization of the ET tube passing through the vocal cords, and chest rise and fall with each ventilation. And air condensations one can see, and 5-point auscultations. And the best method and undisputed is capnography. And the accessories are SpO2 and radiological CXR and USG. Patient should be taken care of in the post-intubation period by monitoring the various aspects, and patient can be initiated on mechanical ventilations if necessary. And nasogastric tube can be put once after intubation, and X-ray should be taken to see a proper positioning, as well as to see whether this peri-intubations problem has come, like pneumothorax, esophageal intubations can be monitored, can be seen. The ABG for post-intubation and maintenance of sedation and neuromuscular blockade is essential. Suppose if the patient has undergone a surgery with the RSI, when they come out of anesthesia, there is a high risk of aspirations. So NG suctioned and removed immediately prior to emergence, and extubation should be postponed until airway reflexes return, and patient should be transported to recovery room with the head of the bed elevated. There are some potential complications of RSA. There may be difficult or failed airway, and it may induce hypoxia in obese patients, pregnant patients, and patients with the pulmonary disease. Of course, hypotension is a possibility. Still, regurgitations and aspirations can happen. So question comes, what to go out? Whether to prefer awake intubations or RSA, or is there any real indications for awake intubation? Yes, there are few indications, like one, if there is anatomical difficult airways predictor or rapid desaturation is anticipated, or when patient is in refractory hemodynamic instability, where RSA may not be safe, and awake intubation with tropical airway with sedation is the preferred one. There are some benefits like spontaneous aspiration is maintained and adverse events are avoided. But there are some drawbacks also. It's poorly tolerated by conscious patients. Require adequate time for topical anesthesia to take effect, so longer time for intubations, and rarely it can precipitate itself complete airway obstructions. So what's your choice, awake or RSA? The choice may be difficult. It's based on the pros and cons of each approach in individual patients, available equipments, medications, and personal Now move on to RSA in different scenarios. Traumatic brain injuries. The airway control is very important for patients with traumatic brain injury because hypoxia and hypercarbia worsens morbidity and mortality. On the other way, laryngoscopy intubation stimulates the autonomic nervous system, so it increases the heart rate, BP, and intracranial pressures, which increases the cerebral edema and worsens outcome. And the drugs which are used for inductions will reduce BP or hypotension, which causes cerebral ischemia and worsens the outcome. So a balance should be maintained and chosen between how to maintain and control the airway faster, meanwhile without causing cerebral ischemia. So the choice of drugs is very important. According to the scenario, it's different. And there are few, like suppose if the patient is hypotensive, or if there's a concern for hypotension, the peri-intubation period, in those patients, there is no need to pre-treatment like load drugs, and it should be induced with the ketamine or etomidate and paralyzed with the succinyl choline acronym and maintenance with the fentanyl and midazolam. There is no need to worry about ketamine, whether it increases the heart rate and BP and ICP. In fact, ketamine's effects, sympathomimetic effects of raising the BP, it increases the cerebral perfusion pressures, so it decreases the cerebral ischemia. Another thing is they say it increases the ICP, but it's not been proven. In fact, because it's analgesic and sedative, it decreases the cerebral metabolic rate and it decreases the ICP also. So ketamine is a good choice of drug when patient with hypotension. Whereas in normotensive patients, hypertensive patients, before induction, they are treated with the fentanyl or lignocaine to blend the pressure response. And the choice is propofol or etomidate. Obviously, ketamine is avoided because it increases the heart rate and hypertension, BP. And succinyl choline or acronym can be used and they are maintained with propofol. Sorry. There are a few points about various drugs in TBA. Normally, people think that succinyl choline causes fasciculation, it increases ICP. It's not shown, and various studies have proven it did not increase the ICP. In fact, using succinyl choline, the airway is controlled faster, and ventilation can be achieved early, so that hypoxia and hypercarbia can be avoided, which in fact decreases the ICP. Opiates are regularly used in fentanyl and remifentanil. Lignocaine, as already I mentioned, it suppresses scopy response and is being used regularly. But recent evidence shows it's not so. But still, it can be used in the patients who are BP is normal. But it should not be used in patients with hypotension because it itself causes hypotension. And rocuronium finds a place in choline-contracted patients. But make sure that you sedate the patients in the post-intubation period because of its long-acting action. RSA in pediatric patients, it is a standard approach to RSA. The few points like neonates and children desaturate rapidly, and they have a pronounced vagal response to scopy. So atropine is used as an adjunct. And another point to remember is because of larger volume of distributions, doses may be higher than for adults. Obstetrics, the second or third trimester of pregnancy has high risk of aspiration due to anatomical and physiological changes. They desaturate faster, they're more likely to be difficult to intubate. The standard approach to RSA and drugs are as in normal adults, but meticulous attention is given to positioning, pre-oxygenations, availability of difficult airway equipment and expertise. And patient with hypertension and preeclampsia, a pre-treatment with the opiates is necessary, and make sure that you inform the pediatricians that opiates is given so that they will be ready to resuscitate the fetus, newborn. And women should be positioned with the left tilt using wedge or tilted table. Then the RSA in shock, the techniques are different in different forms of shock. In hypovolemic shock, patients should be optimized with the isotonic IV fluids and induced with the ketamine or etomidate. The reasons are shown clearly before. And the neuromuscular blocking agent of choice is succinyl choline acronym. In hemorrhagic shock, fluids as well as blood transfusion as necessary and induced with ketamine or etomidate, intubated with the succinyl choline acronym. In septic shock, in addition to IV bolus, vasopressors can be used. And the choice of drug is ketamine and etomidate with steroids. And paralyzing agent is succinyl choline acronym. In cardiogenic shock, inotropes like dobutamine can be used, and fentanyl to blend the response to scopy. And etomidate will be a good choice of induction agents and paralyzed with the succinyl choline acronym. So in other scenarios like as geriatric patients, the physiological optimization is based on the presenting situation. Suppose it's hypotensive, you resist it as normal, and if they're normotensive or septic patients use vasopressors. The induction agents are depends on the clinical scenarios, etomidate, propofol, ketamine, but care should be taken that the dose should be reduced by half if the patients are frail or hypotensive and the paralysis succinyl choline or acronym. Suppose the patient is status epilepticus, fentanyl as a pre-medication is a good choice, and propofol or etomidate can be used, and paralysis or succinyl choline or acronym. To conclude, in many respects, the conduct of RSA in current emergency practice is far removed from the original descriptions and the principles, but the principles, rapid delivery of a definite airway and avoiding aspirations are still highly relevant, and the indications for RSA largely remains unchanged. Change in the original techniques have tackled several considerations like reducing the frequency of hypoxemia, hypotension, reducing the frequency of failed intubations, and making detection and management of complications more effective. Avoidance of adverse events and successful intubation of critical patients on first attempt can be positively influenced by operator-related factors, including training and experience, equipment selection, and drug choices. Choice of drugs is based on the clinical scenario. Etomidate can be used in patients with septic shock. With the availability of sigmoidus, rocronate might replace scoline in the near future. Delivery of high-quality RSA is not a sole activity and requires an effective team approach to apply appropriate techniques. Thank you.
Talk to the point. And going back to the question asked by Dr. Pramod Roshan, what will be the drugs of choice for patients suspecting an ICH and head injury? Probably that answered the question. Can you just once again answer to that question, sir?
Yeah. So patients with the traumatic brain injury or ICH, the intracranial pressure will be high. So if the patients are hemodynamically stable, they are treated with the fentanyl and lignocaine can be used, and they're intubated with propofol. If they are unstable, again the choice is ketamine or etomidate. Etomidate is a good choice. As I told, ketamine, because of its sympathomimetic effect, it increases the cerebral perfusion pressures, and it's very useful in reducing ICP.
Thank you, sir. One more question, sir.
Yeah.
Having said this, Sugammadex can be safely used to reverse rocuronium. The question is from Dr. Muthukumar. If Sugammadex is not available, will you still use rocuronium for RSI?
That's what I told you. That's only rocuronium is still very good, and when you use it in a dose of 1.2 milligram, the onset is as quick as succinyl choline. But one should be aware that it's a long-acting drug, 30 to 40 minutes, and the induction agents are like your ketamine, propofol, or etomidate. It acts only for about 5 minutes. So make sure that you sedate the patients once intubation is over. So at least for the next 30 minutes. Otherwise, patients will be awake, aware, but they'll be paralyzed. Suppose if this is a scenario in a patient with ICH or a traumatic brain injury, this will further increases the anxiety and all these things will increase the heart rate, BP will increase the ICP and worsens the prognosis. So yes, rocuronium still can be used in the absence of sigmoidus.
Hope that answered your question, Dr. Muthukumar. If no more questions, we'll move on to the next session. Sir, thanks a lot, sir. Dr. Shekhar.
Thank you, Nishan.
Thanks for the wonderful talk, sir.
Thank you.
So going on to next session, you proceed with the RSA. If you're not able to proceed with the RSA, you are held up. So that leads to a situation like can't intubate and can't ventilate scenario. So how to go about it? That is a nightmare for every intensivist anesthesiologist. So Dr. Venkatraghavan, sir, Assistant Professor in Anesthesiology, Government Mount Vernon Medical College, and also is a consultant in Raksha Hospital. Over to you, sir, on CICV. Thank you, sir. We're not able to hear you, sir. Sir, can you hear us? So we're not able to hear you, sir. Unmute, Airka.
Okay.
Sir.
Is it audible now?
Yes, sir. You're audible now, sir. Yes, sir.
Thank you. Thank you, Nishant.
Thank you, sir.
Thank you, Nishant.
Yes, sir. Please.
And once I'd like to thank SKS Hospital Administration and Nishant for giving me this opportunity. So just my topic is after Satya Prakash and Shekhar, I think almost 1/3 of my topic is already covered by them. So now we are rounded up in a scenario, cannot intubate and cannot ventilate. So before that, I want to touch some of the basic topics of difficult airway. So the objectives of this talk is difficult airway, what and how to manage, and what are the peculiarities of ICU patients, why it is important. And algorithms, we are going to touch two things. That is difficult airway society algorithm of UK 2015 and IDA algorithm of 2016, and how to manage the CACO and how to prevent it. So incidence of difficult mask ventilation is usually 1 to 2 per 100 cases, and if impossible mask ventilation is 1 to 2 per 1,000 cases, and difficult laryngoscopy is 1 to 18 per 100 cases, depends upon their experience and expertise. And failure of supraglottic airway devices 2% usually with the LMA and flexible, and 1% with ILMA and PLMA. And unsuccessful intubations are usually 5 to 35% per 100 cases, depends upon the experience. And CACO is usually in 0.01 to 2 per 10,000 cases. So risk with the ICU patient. Just a minute. Small problem with the mic. Okay, thank you. So what are the risks associated with ICU patient? Because they are more prone for oxygen desaturation hypoxemia because of the reasons already explained. Because variety of clinical conditions, including sepsis, pneumonia, pulmonary edema, ARDS, trauma patients are at risk. So maximizing pre-oxygenation is therefore very crucial. Just HFNC already, the question is also there. So in high flow nasal oxygen in ICU and OR, it's called THRIVE. It is transnasal humidified rapid insufflation ventilatory exchange is very useful in these patients. So just a small difference between a conventional face mask ventilation and the high flow nasal cannula. So here usually 10 to 15 liters is kept as a flow rate. It's 100% oxygen. Usual uptake time is only 6 to 8 minutes. So once you use high flow nasal cannula, usually the flow ranges can be increased from 30 to 60 liters per minute. And usually your uptake time is prolonged. Median is 14 with the ranges of 5 to 65 minutes. So almost your uptake time is prolonged. Thereby it allows you time and comfortableness to intubate comfortably. So why? Because it extends the safe apnea time, helpful to reach your ultimate saturation quickly. Thereby it helps for the intubation. So it's a difficult airway society algorithm. What it says, actually it has 4 plans. It is plan A is face mask ventilation and tracheal intubation. And plan B is maintaining oxygenation using supraglottic airway devices. And plan C is rescue face mask ventilation. And plan D is emergency front of nurse access. You will see individually. So face mask ventilation and tracheal intubation, already it has been adequately explained. So now with the help, we can optimize the head and neck position. So pre-oxygenation. So adequate neuromuscular blockade can be given, depends upon the need. So direct and video laryngoscopy, maximum 3+1 attempts are allowed. And with the help of external energy manipulation and bougie, we try to maximally ventilate and we try to intubate the patient. If we succeed, we can proceed with the confirmed tracheal ventilation with the capnography. If not, declare failed intubation and proceed to plan B, that is maintenance of oxygenation by the supraglottic airway devices. Usually second generation devices are preferred because of their best fitness as well as the prevention of aspiration, and change of device and sizes can be done in the repeated attempts, and maximum 3 attempts are allowed to oxygenate and ventilate the patient. If you succeed, then you are left with 4 options. Wake up the patient or intubate the trachea via the supraglottic airway devices if you attempt an ILME, or proceed without intubating the trachea or tracheostomy or cricothyroidotomy. If not, if you're not able to succeed, it's a declare failed supraglottic airway device ventilation. So then we have to proceed again with the face mask ventilation. So if face mask ventilation is impossible, paralyze and final attempt at face mask ventilation is attempted, and use of 2% techniques and adjuvants, whatever it may be, we can use. If we succeed, better wake up the patient. If not, declare a scenario of CICO, cannot intubate, cannot oxygenate, and proceed to emergency front of nurse access, usually the scalpel cricothyroidotomy. So failed intubation, failed oxygenation, a paralyzed non-anesthetic patient, immediately call for help and additional help, continue 100% oxygen, declare CICO, and proceed with emergency front of neck access. Usually standalone procedure is scalpel cricothyroidotomy. What our Indian algorithm says, that is All India Difficult Airway Society in 2000 guidelines issued. So usually 5 steps are described here. Step 1 is pre-oxygenation induction of anesthesia. Step 2 is laryngoscopy and tracheal intubation. And step 3, the insert supraglottic airway to maintain oxygenation. Step 4 is rescue face mask ventilation. And step 5 is emergency cricothyroidectomy. So almost all steps are similar to DAS guidelines. Here, the step 1 allows 2 persons, that is with one experienced person, to attempt optimize oxygenation. Induction can be determined or ketamine, and cricket pressure can be used, IPB with Becker mask. Step 2, laryngoscopy. Here, the difference is continuous nasal oxygen flow with the 15 liters or HFNC can be administered throughout the attempt of airway manipulation from oxygenation to the intubation. Maximum of 2 attempts only allowed in this protocol. So mask ventilation in between the attempts and all other things are almost going to be the same. So if face mask ventilation are successful, we can proceed to capnography. If not, we can proceed to supraglottic airway device rescue. If face mask ventilation unsuccessful also, we can make a single attempt of intubation and we can go to the step 3. Step 3, the same, continue oxygen, second generation supraglottic airway devices, and maximum 2 attempts are only allowed in the supraglottic airway device attempt also. So in between you can oxygenate. So if not, then proceed to the rescue face mask ventilation. If not, proceed to step 5. Here it is called complete ventilation failure. That is emergency. Advised is emergency cricothyroidectomy. And separate algorithms are also issued for the obstetrics and pediatric patient. And step 1 to 4 is almost similar in both. And additional step is if there is any failed oxygenation, you have to proceed for periportum cesarean section within 4 minutes of the cardiac arrest. And also in pediatrics, almost things are same. In step 4, in the emergency surgical airway access, 2 options are given. If less than 8 years, if surgical help is available, you can go for tracheostomy. If not, less than 5 years, you can attempt transtracheal needle puncture. If not, you can go for cricothyroidectomy. More than 8 years, you can attempt cricothyroidectomy. It is the guidelines of the IDA. So now we are landing up in a dreadful situation, CICO. It is the most dreadful scenario in airway management. It's an anesthesiologist and intensivist practice. This includes the plan D of the Difficult Airway Society. So front of neck access is the solution. So when you are already landing up there, you are exhausted all the intubation attempts of maximum 4 attempts and LME or oxygenations of 3 attempts you have exhausted. So next you are going for the front of neck access. Standalone procedure is the scalpel cricothyroidectomy. So different countries, different bodies have issued so many different algorithms, but ultimate endpoint is scalpel cricothyroidectomy in all the standalone procedures. So how to do that? So it's a handshake with the larynx. First, you try to assess the thyroid cartilage and then try to assess the cricoid cartilage and find the cricothyroid membrane and we can proceed further. So what are the gadgets needed? It's a scalpel blade, bougie with the cord tip and 6 mm intratracheal tube is the gadgets needed for this. So once again repeat, identify the cricothyroid membrane, make a transverse tap incision through the cricothyroid membrane, rotate the scalpel so that sharp edge points caudally, pulling scalpel towards you to open up the incision, slide cord tip bougie down the scalpel blade into the trachea and railroad the tube into the trachea. Just you will see a small video. Okay, Jenny, I'll continue to talk and the end I will play the video.
Yes, sir. Sure, sir. Please, sir.
No problem. So what the journal says, it's the British Journal of Anesthesia, volume 115 and issue 6 says that serious situation arises when attempts to manage the airway by tracheal intubation, face mask ventilation, supraglottic airway devices fail. So that ultimately lead to hypoxic brain damage. So that the situation is not rapidly resolved unless. So the key features are the CACO progress to front of neck access should be declared. A didactic scalpel technique has been selected to promote the standardized training. Placement of white bore through the cricothyroid facilitates normal minute ventilation with the standardized breathing system. High pressure oxygen through narrow bore canal is associated with serious morbidity, and all anesthetists should be trained to perform surgical airway. So training should be repeated at regular intervals to ensure the skill retention. So NAP review, it's a national audit project that is conducted in UK. It says that maximum, the first attempt at tracheal intubation is your best attempt. So prepare yourself prepare the patient, prepare the gadgets, attempt, and maximally try to intubate the patient at the first attempt. So some of solutions also the NAP4 study has given. So regular training in both technical and non-technical elements is needed in order to reinforce and retain the skills. Success depends on decision making, planning, preparation, and skill acquisition, and all of which can be developed and refined with repeated practice. So what are the measures we can take to prevent CACV? Assess the airway before the paralysis. We found difficult, ask for help. Have a airway management strategy, weigh the risk of paralysis, and adapt. That is, change of plates, bougie, and external maybe maneuvers can be attempted. When you can wake up the patient, don't hesitate to do that. The strategies makes the first attempt at tracheal intubation your best attempt. Video learning yourself as the first choice. Shortly, it's going to be declared. And second generation supraglottic airway devices are usually preferred. And high flow nasal oxygen while attempting intubation we maintain. So optimizing the position and training in CACV management is very, very essential. So usual problems faced are problems in decision making. So delay in progression to tricothyroidotomy is usually one of the dreadful situation. And knowledge gaps, not understanding how the equipments are working, and system failures and technical failure should be corrected for the better management. So other options are needle tricothyroidotomy, transtracheal jet ventilation, and percutaneous tracheostomy. The ultimate goals are securing airway, ensuring ventilation is always the priority. And thus, UK has provided a guidelines for difficult airway management. A proper assessment, equipment guard, training hands, and call for help is always recommended. And guidelines can be adopted to fit to local needs and resources, but can't be deviated. So every anesthetist and intensive should be trained in CACV and surgical airway management. So if you follow all these guidelines and everything, your heart and lungs will say thank you, and also thank you to all. Thank you. Just I'll try to play the video in. You can maintain a gentle traction, and you can introduce a code bougie. Yeah, you can introduce a bougie through the opening you have made. We kept in the parallel to the flow along the line of the trachea. Should introduce further. Rotate the bougie. Keep the line with the trachea. We kept in 10 to 15 centimeters. Usually 6-size endotracheal tube is usually advanced to the opening. It's better to be introduced in a rotating manner. That way the injury and further things can be avoided. In this position, we can remove the bougie. You can confirm with confirmography the position of the things. Thank you.
That was wonderful, sir.
Thank you, Nishant. I will share the video after that you can play. Yeah.
Yeah, sir, sure, sir. I'll
Okay,
put
so
it in the delegate group, sir. Sir, one more question for you, sir. Sir, in scalpel cricothyroidotomy, in place of a boogie, can we use ETT? Which size preferably?
6-size endotracheal tube is usually they are advised.
Yes, probably sir had answered that question in the talk itself. That I hope that answered your question, Dr. Kiran Kuraning. I don't see any more questions in the chat box. If you have any more questions, you can just put up in the chat box. We will even take it to the at the end of the next talk. So thanks, Venkatraghavan sir, for your time and sharing your knowledge. So moving on to the next talk, I invite Dr. V.M. Balasubramaniam, consultant anesthesiologist from Ganga Hospital, Coimbatore. So having intubated, so the next thing is do no harm for the patients. So he's the consultant anesthesiologist, Ganga Hospital, Coimbatore. He did his MBBS from Madras Medical College and a diploma in anesthesia. And to note, he holds the gold medalist. And he did his MD anesthesiology from Grand Medical College in Surgery Group of Hospitals, Bombay, and he did his FRC in EDIC. And his experience currently working as lead consultant in the Department of Anesthesia and Intensive Care, Ganga Hospital, 21-bedded unit, carrying trauma, burns, and surgical patients. And currently, he's working on timing of fracture fixation polytrauma and lactate-based resuscitation in polytrauma patients. Areas of interest are resuscitation polytrauma patients, timing of fracture fixation, imaging in polytrauma and infection control. And as we all know, he's an invited speaker in various critical care and anesthesia meetings. Over to you, Dr. Bala sir, on do no further harm to the patient on ventilator-associated pneumonia and ventilator-induced lung injuries. Over to you, sir. Thank you, sir.
Can you?
Yes, sir. Yes, sir. Yes.
Yeah. Okay. So moving from intubation, now we are going to be about do no harm in ventilation. We all know at a time 70-80% of our patients are on ventilator, and one side it is a life-saving measure. At the same time, you can create a bit of a problem if you are not paying attention to the parameters there. It's not moving. The slides are not moving. Yeah.
Yes, sir. Now it's moving. Yes, sir.
Yeah. So if you look at an ICU, there are an average around 150 to 180 activities per patient per day we are doing in ICU. And in that, they've reported 80 to 90 adverse events per 1,000 patient days. So the cost of adverse events is very substantial. And usually it is a multifactorial. The patient factors, healthcare worker factors, administration and environment factors. All these can cause harm to the patients. And particularly in ventilation, it is a double-edged sword. And one of the important thing is, this is one patient where we have recently, he just came with a simple lung injury and rib fractures, and end up in having a ventilator-induced lung injury, the way we ventilated and the way we have given the volumes and pressures. And end up in spending nearly a month in the hospital. And it is the complications that increases the cost of care. So it is very important. We need to pay attention. Why it is important is because length of stay increases, your cost of care increases, and overall the patient satisfaction also go down. It's because of the complications. First complication is a ventilator-induced lung injury, because it's not a specific disease entity. It's a constellation of pulmonary consequences of mechanical ventilation, both in the disease, and it also happens in the normal lung also, because its lung is not a homogeneous structure in our ICU. It is different parts of the lung has a different specifications, and not all are the uniform one size alveoli. It is all a different size and different volumes and different pressures, and it is characterized by various pathological changes in the lung. And it is the stress applied to the lung and the deformation, which is the strain of the lung units, are the major factors which causes the ventilator-induced lung injury. And it is actually, aptly say, it is not only ventilation-induced lung injury, it is actually it's contributing ventilation-induced total body injury. So what are the various injuries we can induce in a ventilated patient? Is volutrauma, barotrauma, biotrauma, atelic trauma, and also oxygen toxicity, and the recently introduced patient spontaneously induced self-inflicted lung injury in a spontaneously breathing patients. And these factors, they're all not new. Actually, when Tierney first described in 1960s, so where they noticed that traditionally ventilated with the high volumes, and at that time its main aim is to maintain the oxygenation. So that leads to a lot of lung changes and barotrauma. And subsequently, over the years, we understood there are multiple other injuries also we are creating, and the bedside or the bench investigations lead to bedside various treatment modes also changes over a period of time. So if you look at the ventilation lung injury, it's both ends, in a high volume and high pressure in one end, which causes the volutrauma and barotrauma, which normally in the upper part of the lung, which causes a small part of the normal lung, which is mainly this is called the baby lung. And the lower part, which is in the low volume and low pressure ventilated lung injury, it's mainly due to the repeated opening and closing of the alveoli in the lower ends. So it is the higher end is too much of volume and pressure in the top end, and the lower end, just repeated opening and closing at the low lung volumes, causes the ventilator-induced lung injury in both ends. So the volutrauma is mainly in the non-dependent bullae, or probably due to the over distension of the alveoli, and in the dependent bullae, where it is in the lower end, which is sort of collapsed due to consolidation, flooding of the alveoli, and this repeated opening and closing of the airway causes the atelectasis trauma. So what mechanisms causing this airway injury? It is like, you see this sort of ventilation with a low volume and the ventilation with a high volume. At the low end, which is mainly the basal lung units, which is a repeated opening and closing, which causes the structural consequences in the lung, which is normally leading to the formation of pulmonary edema, increased alveolar capillary permeability, which leads to flooding of this alveoli with a lot of fluids. And also in the higher end, where there's a top end, which is over distension of this lung, which causes the disruption of the epithelial cells, and also the capillary integrity also damaged, leading to air leaks and flooding of these alveoli. So both ends, it causes a structural consequences, changes in the ventilation, the normal ventilation in the higher end and the lower end, and which also leads to a lot of biological alteration, which is recruitment of these polymorphonuclear leukocytes, which flood this alveoli, which causes a lot of inflammatory mediators coming into the lung, and which eventually leading to the biotrauma, which is the release of mediators like tumor necrosis factors, interleukins, and which in turn leads to recruitment of more alveolar necrophages and neutrophils, and which also spill over into the systemic circulations, which eventually leading to the multi-organ dysfunction and death of this patient, which eventually causes the ventilator-induced total body injury, which I mentioned earlier. So if you look at that, the experimental data from 1960s, 1970s to the point of 2022, we were introducing more sort of a trauma because of the high inspiratory pressure, usually, which is in the early stages, which we thought causing the volutrauma and barotrauma. And subsequently, it's the ventilation, the repeated opening and closing, which we recognized at the low lung volume also contributed this atelic trauma, which in turns leading to a lot of inflammatory mediator release, which causes the biotrauma. So, which is all recognized in the early 90s. And this also leads to a lot of clinical data in our approach. Initially, we tend to allow this low tidal volume ventilation with the permissive hypercapnia. And then subsequently, we moved on to the open lung concept, where we put a lot of PEEP and opened alveoli. And subsequently, we also various pressures we try to limit and causing the limited damage to the lungs. So the setting of the ventilator also followed the experimental and clinical data, where we started with various, which I will discuss in the subsequent slides. So if you to summarize this, what are the factors which is contributing to the ventilator-induced lung injury? The top two is predominantly is a volume as well as a pressure. So the pressure and volume is the main factors which causes the ventilator-induced lung injury. And in pressures, we initially thought it's a plateau pressure. Then subsequent experimental data and the clinical data leads to our understanding about it is not only the plateau pressure, it is the driving pressure as well as the positive end expiratory pressure, which is which called the PEEP. At the end of the expiratory phase we apply, also contributes a lot of ventilator-induced lung injury. In the whole process, we also tend to forget this flow and rate also contribute at a significant amount, and subsequently leading to the current concept, it's a power. So the mechanical power, which is contributing, which is takes into account to this volume, pressure, flow, and rate, everything put together, and as a combined factor contributing to the ventilator-induced lung injury. So the first breakthrough or first paper came in 2000, which clearly shows where they compared the ArtsNet paper, which compares the ventilation of 12 ml per kg body weight of the predicted body weight and compared it with the 6 ml per kg body weight. And what they found, it's lead to an absolute reduction, 9% reduction in mortality. And also it increases the number of ventilator-free days, and that's not no significant difference in the barotrauma, but overall, it showed a 9% overall reduction in mortality by just decreasing the tidal volume from 12 ml per kg body weight to 6 ml per kg body weight. And they also put it a limitation of the plateau pressure from 50, it has come down to 30. So the low tidal volume group, where it's a 6 ml per kg body weight, and the high tidal volume is a traditional where with 10 to 12 ml per kg body weight we apply. And there's definitely reduction in the mortality. So this is the first breakthrough where it has clearly shown a reduction in the lung tidal volume ventilation has made a significant difference in the mortality. Then subsequently they looked at the pressure. Is it the plateau pressure, which is a very simple, easy measure to measure, that is contributed to the ventilator-induced lung injury? or something else, then they looked at it, this is transpulmonary pressure, which is basically the alveolar pressure minus pleural pressure, which is a sort of, when they looked at the people who have a ventilator, actually referred for the ECMO ventilation, when they adjust the PEEP according to the transpulmonary pressure, they found as a lot of people, this didn't require ECMO. They managed with the traditional 6 ml per kg body weight and a limiting transpulmonary pressure 25-30 centimeter of water. So they thought this is a transpulmonary pressure, which is limiting the transpulmonary pressure 25 to 30 and adjusting your PEEP according to the transpulmonary pressure, and made a difference in the ventilator-induced lung injury. And they also think it is the transpulmonary pressure as it truly reflects the stress of lung parenchyma. And it's also, they use the transpulmonary pressure to help in the titration of the PEEP. So all put together, they think the transpulmonary pressure, limiting the transpulmonary pressure below or maintaining between 25 to 30 is an ideal way to maintain the, preventing the ventilator-induced lung injury. And subsequently, they also looked at the PEEP. What is an ideal PEEP? Again, we don't have a data, clinical data, to which has definitely shown which is the ideal PEEP. But you need to look at it, the PEEP, as preventing over-distension in the normal alveoli, as well at the same time, preventing a de-recruitment. If the PEEP is not good enough, with the normal tidal ventilation, your alveoli is tend to collapse and recruit in between the tidal ventilation. So that can cause atelectatic trauma. So your aim of the PEEP is to prevent the de-recruitment of the alveoli at the low pressure and preventing over-distension at the higher pressure. But how do you titrate this PEEP? And there is no ideal measure, but you can use the odds net table, which uses the PEEP and FiO2 table, or you can use the ventilator parameters like a driving pressure, or you can use the transpulmonary pressure to titrate the PEEP to the level where it is just above the lower inflation point or around the lower inflation point. But again, is it a high PEEP versus low PEEP studies? If the high PEEP or low PEEP is better, definitely the high PEEP doesn't show any mortality benefit. The largest meta-analysis of French, Canadian, and the odds net study didn't show any benefit of high PEEP ventilation in the overall mortality of this patient. So, which is ideal pressure? Again, they move on to this Amatos paper, which came sort of in 2015. They looked at something different called a driving pressure, which is nothing but the plateau pressure minus the PEEP, which is the driving pressure, which is applies the pressure applied during the inspiration, and it causes the stress, causes of the opening of the alveoli. So what they looked at it is, if you look at the first graph, as the driving pressure increases, and the lower part of the graph, which showed the mortality, the survival benefit, there is definitely, as the driving pressure increases, mortality also increases. Look at the second graph, as the driving pressure remains stable, even though the plateau pressure increases, but there is no difference in the mortality. Look at the third graph, actually, as the driving pressure is decreased, the mortality also decreased. So what they found, it is a retrospective analysis of odds-net patients, but they definitely shown as a driving pressure targeted ventilation definitely improves the mortality, and limiting the driving pressure below 15 centimeter of water definitely improves the mortality and decreases the ventilator-induced lung injury. Moving on, they combine together all the driving pressure and the tidal volume, respiratory rate, flow, PEEP, all put together and create something called a mechanical power. It is the energy applied during the tidal ventilation throughout the respiratory cycle. Can this predict the patient who will get a ventilation-induced lung injury? Yes, they try to put this, it's like, full book. Rather than applying the individual chapters, you look at the whole book and apply these things. But we are not there yet, whether this mechanical power or the energy applied during the tidal ventilation and minimizing to less than lower joules will benefit the patient in preventing the ventilator-induced lung injury, not yet there. So moving on, so what are the ways we can prevent ventilator-induced lung injury? There are 4 strategies we can look at it. One is the ventilation strategies. How do you put it? Low tidal volume, limiting the plateau pressure, or in other words, limiting the driving pressure less than 15 centimeter of water. So these are the three. So you are going to give a low tidal volume, minimizing the driving pressure less than 15 centimeter water, and optimal PEEP. Select the PEEP based on the lung mechanics. And you also put in a lot of adjunctive strategies, either introduce the PEEP, and as well as you put on a patient in a prone ventilation. So basically you are converting a non-homogeneous lung to as much as a homogeneous lung as possible. So you are opening up the more alveoli. The baby lung has more and more alveoli available for a ventilation. Then the pharmacological intervention, like, you have paralyzed this patient and limiting the patient's respiratory effort. So that can also help in. And also there is a new thing that hemodynamics also play an important part in creating the ventilator-induced lung injury. So too much of pulmonary pressure, it also creates a pulmonary edema by causing the leaky capillaries where the flooding of the alveoli happens. So limiting your mean pulmonary artery pressure during the period of mechanical ventilation also helps in limiting the ventilator-induced lung injury. So overall, we need to combine these things, and you have to individualize the ideal target for this. And it's not only applied during our ward rounds or one time, it has to be, because our patients are not having a homogeneous lung, and it is not a fixed lung throughout the day. And it is a dynamic process, and it varies from time to time. And the baby lung, or whatever the lung which is available for ventilation, it's not fixed. It is a dynamic. It moves from low to high. So you have to individualize the mechanical ventilation strategies for your patients. Even you going around the tidal volume, even below 6 ml per kg body weight. So this is the hemodynamics, which I said you also pay attention to the hemodynamics, because the capillary stress failure is an important contribution for the ventilator-induced lung injury. It causes increased pulmonary blood flow, and it's also causes the flooding of the alveoli because of the increased mean pulmonary artery pressure, causes the edema formation in the high permeability leaky capillaries into the lung. So moving on, the factors which helps to prevent the lung injury, which is the evolving concept in the lung protective strategy, is starting from low tidal volume, limiting the plateau pressure, and a high PEEP open lung approach, where you maintain the PEEP enough to prevent the de-recruitment of alveoli, at the same time in the top part, preventing over distension of the alveoli. So low driving pressure, less than 15 centimeter of water, and limiting the plateau pressure less than 30 centimeter of water. And you allow certain amount of permissive hypercapnia. If it needs to be done, you go down the tidal volume even 4 to 6 ml per kg body weight. And ultimately, you reduce the driving power, which is leading to reduce the cumulative injurious strain on the lung units which you are applying. So our goals of ventilation should be maintain the gas exchange, reduce the work of breathing, at the same time, minimize the ventilator-induced lung injury using the protective ventilation strategy, which is available at this point in time, is limiting the tidal volume, limiting the plateau pressure, and limiting the driving pressure. Maybe in future, we will be able to achieve some sort of a value for the power, mechanical power. So the joules, what we are applying to each ventilator cycle can be titrated to minimize the ventilator-induced lung injury. So moving on, the second part where it is other harm we can create is the ventilator-associated pneumonia. Again, if you look at our patients, at a time, the incidence anywhere between 10 to 15% of our patients develop ventilator-associated pneumonia, and it is one of the important or a more common nosocomial infection in our patients. The problem with that is the diagnosis. What diagnostic criteria to apply? We have two. One is the clinical criteria. Another one is the CDC criteria, which is mostly used for a surveillance definition. Pneumonia occurring 48 hours after endotracheal intubation. That's very important. And the new lung infiltrates plus clinical evidence that the infiltrate is of an infectious origin, which includes new onset of fever, purulent sputum, leukocytosis, and decline in oxygenation. So it applies the clinical criteria where there is a new infiltrate applied with onset of fever and purulent sputum, radiological criteria, and also microbiological criteria where you look at the culture sampling. So it's a lot of subjective elements are there in the diagnosis, which makes it difficult to diagnose absolutely the VAP in our ventilator patients. A lot of patients, what we think as a VAP may not be a VAP. It is just a ventilator associated injury, which is reflecting as a VAP. We tend to overestimate or tend to overtreat these patients with antibiotics because, especially where I work as a trauma ICU, a lot of patients they present exactly because of the inflammatory response. They produce the same features like temperature, worsening oxygenation, and it can be increased secretions, and it's a increased white count, and they also have decreased oxygenation. All this can be present both in VAP as well as ventilator-induced lung injury, as well as in other injuries like contusion, pulmonary contusion, or pulmonary edema, or any other ARDS due to any other reasons. All these can produce exactly the similar picture, which makes this diagnosis of ventilator-associated pneumonia a little bit difficult for us. So, so that is the best clinical criteria or clinical diagnosis which is available for us. So to circumvent this, the CDC, Center for Disease Control in US, they come with something called a ventilator-associated event. It is triggered by the sustained increase in ventilator settings after a period of stability. So they put it 3 conditions: VAC, which is a ventilator-associated condition, and then infection-associated ventilator-associated condition, and a possible or probable VAP. So the ventilator-associated event has to be first it's triggered by sustained increase in the settings after a period of stability. So how do we come to that? Increase in PEEP of more than 3 centimeter or FiO2 of more than 20 basis points, we consider as the ventilator-associated condition. That's the first criteria. Then moved on, if the patient develops temperature more than 38 or less than 36, associated with the increased white count of more than 12,000 or less than 4,000, and if they need an antibiotic escalation for more than 4 days, then we call it as infection-related ventilator-associated condition. And then subsequently, it's a microbiological confirmation, then we put it as a possible or probable VAP. So the problem with the ventilator-associated is the most common nosocomial infection. And as I said, it has put some diagnostic difficulty because of the varying definition and the subjective criteria and poor correlation with the histology. All this make this is a potential problem for us in diagnosis. And this also ventilator-associated event, which should be applied as a surveillance definition or for a day-to-day clinical decision-making process, also makes it difficult for us to put in, which is a pneumonia or a ventilator-associated event, where not all ventilator-associated events are ventilator-associated pneumonias. Only 25 to 35% is actually a ventilator-associated pneumonia, and where we need to start antibiotics and treatment. There is an attributable mortality because of the VAP, about 10 to 15%, which causes increased length of stay, and ventilator days also increase. And obviously, it increases the cost of care also. So this I already explained, the ventilator-associated event, where we just to use this for a surveillance definition, the patient on mechanical ventilation for more than 2 days has to be a criteria. And then subsequently, there is a period of stability, and this patient had an increased PEEP requirement or decreased oxygenation of more than 20%, then we call it as a ventilator-associated condition. And then have this temperature and white count increase or antibiotics for more than 4 days, we consider as an infection-related ventilator-associated complication. And subsequently, if the microbiological testing is positive, then we call it as a possible or probable VAP. So in order for the VAP to occur, there are 3 factors are critical. One is colonization of the oropharynx with the pathogenic microorganisms, and aspiration of these organisms from the oropharynx into the lower respiratory tract, and compromise of the normal host response mechanisms. All this happens because of your endotracheal intubation, which can cause this oropharynx colonization, and aspiration because of the pulling of secretions due to your reflexes are obtended, and it compromises the normal host defense mechanism like a mucociliary clearances. The source for this organism has to come from 2, either from the endo, like from the patient itself, or from the outside, the environment. So there are 2 factors which can contribute, either endo or exo. These patients can have a source of organisms coming into the patient, causing the ventilator-associated pneumonia. So this is the pathogenesis, where you can see that aspiration, intubation procedures, biofilm formation, contaminated secretions, contaminated respiratory equipment, all this can contribute to the development of pathogenesis of ventilator-associated pneumonia. So the common causative organisms, if you look at the literature, it's like most of the literatures are Western literatures. It's a gram-positive is the most common organisms in the Western literature. But in our Indian setup, it's mostly gram-negatives. And the viral is and fungal, it's to less extent. It depends on your intensive care and the type of care, type of intensive care. It's a medical or a transplant. They can have a viral and fungal VAP also as a main causes. But for us, it is in a trauma ICU, mostly the gram-negative problem, predominantly the Pseudomonas, Klebsiella, and Acinetobacter are the common causative organisms, which causes the ventilator-associated pneumonia. And how do you diagnose this in these patients? And uses a non-invasive semi-quantitative culture to diagnose the VAP. This is the IDSA guideline, which showed how do you diagnose the VAP. You can use the non-invasive from the ET tube as a semi-quantitative culture, which is good enough to diagnose the VAP. And always send, when you take a cultures, always send a routine along with the culture, because it helps in the early starting of empirical treatment. The gram stain will show whether gram positive or gram negative. So you can start the antibiotics accordingly. If you use the quantitative threshold, on the other hand, the threshold is for if you take an ET aspirate, it should be more than 10 to the power of 5 colony forming units. If it is a bronchoalveolar lavage, it should be more than 10 to the power of 4. Or if it is protected specimen, is at more than 10 to the power of 3 colony forming units. So that should be the criteria for the diagnosis of VAP. So the biomarkers, so the role of biomarkers in diagnosing the ventilator-associated pneumonia is a little bit of not recommended by the IDSA guidelines. The initiation should be initiation of treatment should be based on the clinical criteria, not necessarily the biochemical markers like the procalcitonin, STREM. It doesn't add any clinical accuracy, as their sensitivity and specificity are very low in comparison to the clinical criteria alone. And again, your modified CPS score, it does not add to the diagnostic accuracy of this VAP. And but possibly the procalcitonin is helpful in stopping the antibiotics. When the procalcitonin comes down to less than 10% of the initial value, you can conveniently stop the antibiotics in these patients. This is the modified clinical pulmonary infection score, which shows an area under curve as about 0.72, which doesn't increase the sensitivity or specificity where you can diagnose your VAP. The treatment, there is always a dilemma. Is it whether you use a tracheobronchitis or you need to treat the patient with the tracheobronchitis, or should the patient wait for develop a VAP and treat the patients? If you look at the literature, you don't have to treat the tracheobronchitis, but that is the precursor for the patient to develop ventilator. So you need to balance the risks and benefits at this point in time. So then you have to, if needed, you start the patient to treatment. But literature doesn't support the treatment of tracheobronchitis. The empirical treatment should be based on the local prevalence of organisms and antibiogram. So each unit have their own, should know the antibiogram and the prevalence of the organism.
Excuse me, sir. So sorry for the technical glitch, sir. Sir, I think you should reshare again, sir. We lost your slides.
Oh, okay.
Yes, sir, just kindly reshare it, sir.
Where are you?
Share screen.
Yeah.
Just fast in 10-15 seconds, sir. Just I want you to yes, sir. We are getting your screen now. Yeah.
Okay. So
Yes, sir. Yes. You can start your slideshow, sir.
okay, so the 4 moments of antibiotic decision making is, first question you ask, does my patient have an infection that require antibiotics? And then you need to know whether have I ordered appropriate cultures before starting the antibiotics, and what empirical therapy should I initiate. That should be based on your likely pathogen in your ICU or likely sensitive pattern of your organisms to the organisms which you grow in your ICU. And after a day or 2 passed, and can I stop the antibiotic? You need to know when to de-escalate or when to stop the therapy, and what duration of therapy should be continued for your patients. These are the 4 questions you always ask when you have this patient. So the diagnostic test for VAP, which already I discussed, as non-invasive culture technique and a semi-quantitative is good enough for the diagnosis of VAP. You don't have to have a quantitative cultures all the time. And when you de-escalate VAP therapy in patients for whom an alternative diagnosis identified, you need to stop the VAP targeted therapy, because otherwise unnecessarily you continue the antibiotics for unnecessary and increase the cost of care. If the VAP is the likely diagnosis, then use the respiratory culture results to narrow the therapy. And how long you continue the therapy, 8 days treatment is as good as 15 days treatment. And this is the study in 50 and French ICUs, which showed clearly it's stopping the antibiotic therapy at the 7th, 8th day. It doesn't causes the emergence of a multi-drug resistant or a reinfection. So you can safely stop the treatment of VAP after 7 days. So you decide about the culture and you start empirical antibiotic treatment. After 3 days, you review that whether you are having in the right track. And after 7 days, you can stop safely the treatment for the VAP. Last few slides, I just go through about the prevention of VAP. So there are 4 areas you should think about it: infection control, medications, equipment, and VAP bundle. So there are different ICUs have a different bundles. They increase the number of the. Originally, there are 5 elements in the VAP bundle, which is about think about it is head end of the elevation of the bed, oral decontamination, daily interruption of the sedation, and check the readiness to wean, and your ET tube, and judicious use of stress ulcer prophylaxis and the thromboprophylaxis. These are the main original 5 elements of the VAP bundle. But as we have more evidences available, we start inducing more and more into the equation. And I'll just quickly go through that. So the infection control issues, which is very, very important in prevention of VAP, is health education, which is an important thing in our ICU, because recently I have gone through how much is the knowledge of these nurses. We assume they know everything because every day they think about this VAP bundle elements. But actually, if you go and interview them, their knowledge about the VAP prevention, VAP bundle is all very limited. So the education is very important. Hand hygiene, this is another thing where is the 5 moments of hand hygiene has to be strictly applied, because the contamination in the environment can move into the patient only by the improper hand hygiene. The environmental disinfection, isolation of patients who likely have a multi-drug resistant organisms. And the last is a patient-nurse ratio. This is also very important. The number of where the patient 1:1 ratio, patient-nurse ratio is there is a good chance of preventing VAP. If the nurse ratio is poor, there is always cross-contamination happens, and the incidence of VAP increases in the ICU. And the medications wise, this selective digestive decontamination, which is very useful in a setting where there is MDR pathogens incidence is very low. And the stress ulcer prophylaxis, again, you need to judicially use, because the recent evidence shows the stress ulcer, the routine use of pantoprazole can actually harm the patients, increasing the VAP rate. And oral antisepsis and sedation analgesia is also very, very important in preventing the VAP patients. What about the equipments? Closed versus open suction. This is again, if you extrapolate the literature, there is no difference between whether you use a closed suction catheter or open suction. But in an ICU where you have a limitation of 1:1 ratio, and you have a multiple interventions where your suction cross-contamination is very high with open suctions, and the hand hygiene and the strict enforcement of the hand hygiene every time they do suction is also a difficult problem. So you need to have, you have to balance the risk benefits. And I personally believe the closed suction is a better way in our ICUs, like in open ICUs. And HME versus heat and humidifier, and then there is no difference between one or the other in preventing ventilator-associated pneumonia, but HME has its own advantages as well as the disadvantages. And the subglottic suctioning, which has recently shown as an additional measures, which shows an evidence to decrease the incidence of VAP. So if you are using an endotracheal tube for more than 48 to 72 hours, it's better to have an supraglottic suctioning tubes to put in this patient to decrease the VAP. So this is a guideline from SHIA and IDSA, which shows various approaches which helps in the prevention of ventilator-associated pneumonia. So there are some essential practices like avoid intubation if possible. So there is a definitely evidence to say non-invasive ventilation decrease the incidence of VAP, because obviously you don't have to put the endotracheal tube. Minimize the sedation, particularly avoiding the benzodiazepines, and uses a Dexmed or a propofol, which helps in preventing the patients and prolonging the ventilation. And units which have a weaning protocol definitely has a benefit in decreasing the VAP. Early mobilization of patients also, and on head of the bed elevation about 30 to 45 degrees. Oral care with toothbrush, but avoiding the chlorhexidine. Again, the chlorhexidine has shown increased mortality in a VAP patient. So avoid chlorhexidine, but you do oral care with toothbrushing. Early enteral nutrition and change the circuits only it is visibly soiled. And selective digestive decontamination or oropharynx is only in low MDR prevalence ICUs. These are all additional approaches in addition to essential practices, where in spite of your applying the essential practice, still the VAP rates are very high. Endotracheal tube with subglottic section, which I said, if you're going to ventilate for more than 72 hours, use a tube which has a subglottic section. Early tracheostomy, again, how do that helps is it decreasing the sedation, encouraging the patient which have oral care, and it is helps in early mobilization of the patient, which ultimately leads to direction in the VAP. Post pyloric feeding, again, it's technically difficult, but especially when the patient have a gastric intolerance where a high gastric residual volume, the post pyloric feeding will help in decreasing the VAP. There are also not beneficial effects of various measures like an oral care with chlorhexidine, probiotics, tapered endotracheal tube cups, automated cuff pressure monitoring, silver coated tubes, kinetic beds, prone position, chlorhexidine bathing. These are all shown to be not much beneficial in decreasing the incidence of VAP. And there is also closed ET section. It is neither recommended nor discouraged. As I said, it depends in your ICU. You have to have a more frequent sectioning, and this hand hygiene, monitoring the hand hygiene is difficult. It's better to go with a closed ET section rather than open section every time. And we don't use the catheters. Again, the suction catheters, once used, you need to discard. You don't keep it separately and then use it again, because that increases the contamination and it causes the VAP incidence increases. Those not recommended is the stress ulcer prophylaxis, which you need to use as judicially in those patients where there is a high risk of gastric ulcer. And you don't have to monitor the gastric residual volume unless there is a high potential of regurgitation, vomitings happen. And early parenteral nutrition doesn't seem to be shown any between in decreasing the VAP. The last slide is also important, which is the process monitoring. The various bundle elements of the VAP bundle is nothing but it's a group of measures when you apply together has to shown beneficial in terms of VAP prevention. But it's just looking at the overall outcome. What I want to do is look at the process, individual process, how the compliance with the individual process, that's more important and should be done regularly. And you need to share the process compliance with the process with the unit people, and you need to give them feedback. So that helps in the process monitoring, will helps in the overall surveillance as well as decreasing the incidence of the VAP. So thank you very much. So it's a bit of long, but it gives you a little bit. Do no harm is very important, because actually you might decreasing the length of stay and decreasing the cost of care in your ICU. If you apply these simple measures like preventing the VAP and preventing the ventilator-induced lung injury, just applying simple measures like a volume and pressure. Thank you very much, Nishan.
Thank you, sir. Thanks for a wonderful talk, sir. I don't find any questions chat box, but I have two personal questions for you, sir.
Thank you.
From your experience, what are the two most important things to prevent VAP, sir? Just two important things, which holds topmost priorities?
VAP bundle enforcement and the process monitoring. These are the two things which I found is very, very important in decreasing the VAP incidence in our ICU, because every time we slacken this, which is ultimately it leads to follow-up. The VAP bundle surveillance, if I do that, I knew this is there's a lack of enforcement, and then I go back to education and reinforcing all the bundle elements, which helps in decreasing the VAP. So the surveillance and the process monitoring is the two important things which helps in the prevention of the VAP.
Definitely, sir. And one more question, do you use PPAs regularly in ventilated patients, sir? So guidelines don't ask us to do so. So by practice, do you use it regularly? Do you find it in prevention of J bleed and those things, sir?
Say again, what, sir?
PPAs, use of PPAs, regular use of PPAs in ventilated patients.
So actually, most of our patients are invariably on sort of a PPIs.
Yes.
So I too have, because we don't have we don't have a statistics, or we don't have the studies which showed in our set of patients whether they are all invariably, they're all trauma patients, which normally I deal with as a trauma patients. So they are high risk for a stress ulcer, and they do have now and then when I step down in the PPI usage, now and then there is a patient which has a massive bleeding. So it's end up having reintroduced this PPI again. But actually, I don't have a statistics or a data to support stopping the PPI and decreasing incidence of VAP.
Okay, sir. Sir, actually, we have two questions in the chat box.
Yeah.
So first question from Dr. Pramod Roshan. How to decide ventilator mode quickly on common different systemic complications? I think we have a presentation, I think day after by Dr. Murali, consultant from KMCH, how
Yeah.
to decide on ventilator settings and mode. You can go, you can just give a short answer for this, sir.
Yeah, so the ventilator mode, it is there are a lot of advanced modes. I still 85% of the time I use the volume control mode or pressure control mode, which is more or less it's good enough to our routine patients. And second thing is what we don't pay attention to is these volumes and pressures, because it is a very dynamic situation and I move in and out of the ICU, and then every time you come back, sometimes you set the ventilator for 400. Actually, the patient was taking 600, 700 ml tidal volume. So it is, it's our strategy should not be fixed to particularly, but it should be much more robust. Particularly this volume and pressure are the two important things. Because I do face this ventilator-induced lung injury, more common, which is now more and more I recognize, because we tend to overtreat this patient as a VAP, and actually they are not VAP. After 2-3 days, irrespective I put this polymyxin, irrespective of cholesterol or Zavicefta, these patients still having the same problem. So now we step back and then we hold. We don't put them on antibiotics. We just wait for the inflammatory response. This fever, the temperature, and the tachypnea and the hypotension, you to control symptomatically and allow this patient to regroup themselves rather than bombarding with antibiotics. So the mode wise, volume control mode or pressure control mode, the basic mode is as good as anything.
Agreed, sir. So actually, Dr. Vijay Ravi have answered, have asked 4 questions. I'll start with the first one. Any neuro rehabilitation for critical illness, neuropathy or myopathy?
The first, that is very, very important. It's a very valid question, because we are bit slack in mobilizing our patient. We are very, very worried about this tube coming out, that lines coming out. So we tend to mobilize this patient, irrespective of the patient is on ventilator or not. We tend to mobilize to the wheelchair, or we tend to mobilize this patient. We are not as aggressive like a Western setup where put the bicycle on the bed, but we tend to earlier, second or third day itself, we put the patient on a wheelchair, even with the endotracheal tube. So that is the one thing which helps a patient's well-being. Like, the patient is much more the depression, all those things can be taken care of. Second thing is the positivity about their recovery also is better, and definitely that will decreases the critical illness polyneuropathy, because especially when these patients are long-term on ventilation with the muscle laxants, and again, we don't use much of the muscle laxants. Very, very, very judicious use of muscle laxants. Also, we tend to minimize that. So this helps to minimize the critical illness polyneuropathy.
Yes, sir. So next question, how to measure pleural pressure?
Yes, that's a very, very important question. I don't routinely measure it. It's because very cumbersome. Putting the esophageal balloon in the right place is also makes it difficult. I've done a few times earlier when I was in another unit in UK. But again, that is very, and there is a lot of unanswered question. Is it a one pleural pressure measuring in the position where we put in? Is it as a reflection of the entire pleural pressure? So I tend to now move from the pleural pressure or a transpulmonary pressure into sort of a driving pressure. Now I do look at more as a driving pressure, because I don't know whether that is a good strategy or not, but I do look at the driving pressure, limiting the driving pressure to 15 centimeter water, and makes it easier for us rather than looking at the measurement of the esophageal pressure, because a lot of dicey situations or dicey assumptions made in the esophageal balloon pressure measurement.
Okay, sir. So next question, can we connect endotracheal tube to BiPAP machine in remote place till the patient reaches the tertiary care hospital?
Now, we tend to send patients with the tracheal like a tracheostomy tube. So those patients particularly the quadriplegic patients or the quadriplegic patients, they don't come off the ventilator very high. So we send them patients.
Sorry, question is, can we connect the endotracheal tube to BiPAP, sir?
Same thing. I'm coming to that, because if I can connect it to the tracheostomy tube, you can do that with the endotracheal tube. The only thing is, if you use the BiPAP, again, you need to be very clear in the mode which you are using it. If you use if the patient's breathing spontaneously and then able to tolerate the endotracheal tube, absolutely you can use it. if the patient doesn't breathe spontaneously, the small machines automatically shift into sort of either a pressure control ventilation or a fixed mode ventilation, which can be easily done, and which is fair enough, I think.
Yes, sir. So one more question. So I'll make the question of Chris. So when will you start DVT prophylaxis in a patient with hemorrhagic stroke?
Yes. So this is a very important question. We also had a similar discussion in the morning. So the literature says after 3 days you can start the DVT prophylaxis. But the problem is, if you start a DVT prophylaxis, the intracerebral hematoma, if it increases, then there is a problem. How do you explain? Why do you started these patients? So we have a sort of, we straight away put the patient on mechanical DVT prophylaxis. So that's a day one. Then we look for a decreased in the intensity of this, the Hounslow units, they looked at it, they decreased the intensity of this intracerebral bleed. So that is the time, normally about 5th or 7th day, we start a DVT prophylaxis with the Clexane without so far any increase in the size of the clot or a rebleeding or anything, etc. We are much more forthcoming in SAH and STH than the intracerebral hematoma. So it is not a very clear, but the literature says after 3 days, you can definitely start the DVT prophylaxis. There is a one study which has shown that.
Yes, sir. Suppose there's CVT hematoma, we can start a bit earlier still, if it is CVT associated hemorrhagic.
Definitely.
Definitely. Yes, actually, the question was a bit long. The second part of the same question was, suppose the patient has both limbs amputated, what will you do?
For the mechanical DVT.
Yeah. That was a question from Dr.
Because a lot of time I have a difficulty, because being a trauma patients, they all have an X-fix down the legs. So in that cases, you don't have any option other than wait for them to either the neurosurgeon, we have discussed in neurosurgeon, and we just have a balance it to start the mechanical, or sorry, the pharmacological DVT prophylaxis, or sometimes we tend to mobilize them early. That is what will help them. So because even though the patient's not continuously put on CPM, if the patient is able to have, there is no contraindication to the hip flexion, we tend to put the patient on a CPM machine. So they do an hour of CPM in alternate leg for a day or two.
Yes, sir. And final question, why chlorhexidine do harm in VAP, sir? It should be beneficial, right?
Yeah, the study which is shown, we assume that probably the micro aspiration of the chlorhexidine would have caused that chlorhexidine induced pneumonitis rather than actually this chlor. That is the reason why the chlorhexidine has fallen out of favor. But the earlier VAP bundle elements, we used to put in 2% chlorhexidine as a oral mouthwash. So again, you have to look at it, what volume they are putting in, how they are putting in, how they are sucking out. And again, definitely your endotracheal tube cuff is not a foolproof where it doesn't have a prevent the complete aspiration. So this micro aspiration could have been the cause for the pneumonitis, and that causes the worsening mortality in the patients who had used 2% chlorhexidine as a oral mouthwash.
Yes, sir. Thanks a lot for the answers, sir. Thanks a lot for your time again. And moving on to next, sir. Thank you, sir. Thank you, sir. Yes, sir. So moving on to next presentation, Dr. Lavanya ma'am. So next talk is on approach to ABGs in respiratory failure, because ABG is an important tool where almost all institutes have ABG as a point of care in ER. So knowing ABGs, we can go ahead and ventilate the patient in a better way. So that would be taken by Dr. D. Lavanya ma'am. She is a consultant anesthetist and intensivist at SIMS Chellam Hospital, Salem. She did her undergraduation from Madras Medical College and diploma anesthesia from Kale Park and FRCA from Royal College of Anesthetists and PGDMLE at National Law School, Bangalore. And work experience, she has worked abroad and here in Salem in Manipal Hospital 2008 to 15, and currently she is working SIMS Chellam. And clinical experience, worked in abroad, and after returning to India, she worked in Manipal and then now in SIMS Chellam. Main area of focus, trauma, orthopedic and neuro anesthesia, neuro and medical intensive care. Over to you, ma'am. Lavanya ma'am.
Thank you. Thank you, Nishant. Good evening, everybody.
Ma'am, are you there, ma'am?
Yeah. Can you hear me? Nishant, can you hear me?
Yes, ma'am. Now we are able to hear you, ma'am. Yes, ma'am.
Yeah, I'm trying to share the screen.
Yes, ma'am.
It's visible, right?
Yes, ma'am. You're audible, screen is clear.
Thank you.
Yes, ma'am.
Thanks for the opportunity, Nishant. And being a last topic, I try to be as quick as possible and not taking too much of time on, because I know everybody will be fatigued after the four exhaustive topics for today evening. My topic is very specific, ABG in respiratory failure.
Mute.
So assuming that we all know the basics of ABG and how to interpret and how to diagnose various acid-base disorders, let us focus only on the respiratory system today. Before getting into the finer points, just a broad few things about ABG. Whenever you order for the ABG, always remember it is a point of care test and it is a dynamic test, because once you order a ABG, you want to make the changes then and there. You cannot order an ABG and look at it after few hours and try to treat the patient. After few hours, it is a dynamic and it's always evolving, and the acid-base disorder will change after few hours. And whenever you look at an ABG, always use a stepwise approach. So my talk is going to be mostly based on type 1 respiratory failure and some respiratory acidosis and alkalosis, and few points about mixed disorders. So we all know it's the oxygenation failure or hypoxic respiratory failure, which is the type 1 respiratory failure. So few basic things, just a recap. We all know oxygen is transported from the alveoli, diffuses from the alveoli into the pulmonary capillaries, and majority of oxygen is carried by the RBCs, but which is bound to the hemoglobin, and only very small percentage, only 3% of oxygen is dissolved in plasma. Majority is carried as oxyhemoglobin. And these things are important when you are treating a patient with hypoxia. And remember the oxygen cascade. The partial pressure in the alveolus comes down once it reaches the pulmonary capillaries and the arteries, and when it comes to the mitochondria, it drops down further. This is the oxygen cascade. So in the oxygen cascade, you have to remember at the atmospheric air, the oxygen percentage is 21%, which approximates to approximately to the partial pressure of 160 millimeter of mercury. And once the atmospheric air enters your airway, it is diluted by your water vapor. So the partial pressure further drops. And once it reaches the alveolar gas, it is further diluted by the level of the carbon dioxide. So it further drops to almost 100 millimeter of mercury. And in the ideal situation, the alveolar gas mixture, the alveolar partial pressure should reflect the end capillary partial pressure. But it's we all know, even in healthy lungs, it's not the ideal situation. There will be some mixing of deoxygenated blood. And in the arterial blood, again, the PO2 further drops. The difference between the PaO2, the alveolar partial pressure, and the arterial pressure is the AA gradient. We'll look at it in detail later. And in the tissue oxygen tension, it further drops due to the diffusion distance, and it varies from the tissue to tissue, and at the mitochondrial level, it drops further down. So any small decrease in the partial pressure at the alveolar level will reflect badly at the mitochondrial level. Remember this whenever you are dealing with hypoxic patients. And more than the partial pressure, it is the oxygen content that is important, because how much oxygen is carried per 100 ml of blood. We all know it's majority of oxygen is carried by the hemoglobin. So it is the value of hemoglobin, the amount of hemoglobin in the blood is very important. So each gram of hemoglobin carries around 1.34 ml of oxygen. And assuming that all the hemoglobin is 100% saturated, it is the amount of hemoglobin in the blood multiplied by 1.34 ml. And we have already seen the amount of oxygen dissolved in plasma is very minimal. And so if you want to improve the oxygen content of your blood, you have to improve the saturation of the hemoglobin and the hemoglobin content in the blood. By increasing the partial pressure, it is your very low increase in the oxygen content. And it is not only the oxygen content that is important, because the oxygen needs to reach the tissues. So that your cardiac output is also important, which is given by the equation, the oxygen delivery, cardiac output multiplied by your oxygen content. And understanding the alveolar gas equation is important to understand how your atmospheric pressure, inspired oxygen concentration, and the carbon dioxide levels will cause hypoxia at the alveolar level. Because the normal atmospheric pressure, the alveolar gas is only diluted by your water vapor pressure. So the alveolar partial pressure is the difference between the atmospheric pressure and the water vapor pressure multiplied by your FiO2 and subtracted by your PaCO2 by respiratory quotient. So with the normal atmospheric pressure, it's only the dilution by the water vapor, and keeping the PaCO2 and the respiratory quotient normal, you get the partial pressure around 100. But when the atmospheric pressure drops, for example, in high altitudes, the partial pressure at the alveoli drops almost to 0, given the oxygen but oxygen concentration remains the same. It is the drop in the atmospheric pressure which drops your partial pressure of oxygen at the alveolar level. Similarly, if you increase the inspired oxygen concentration, your alveolar partial pressure increases dramatically. In spite of your FiO2 being 0.21, if it increases to 1 with 100% oxygen, your partial pressure increases to around more than 600 millimeter of mercury. Similarly, if you double your carbon dioxide level, if you apply instead of 40, you increase the alveolar carbon dioxide partial pressure. If it doubles, it almost halves your oxygen pressure at the alveoli. So the alveolar partial pressure depends on your atmospheric pressure, inspired oxygen concentration, and your carbon dioxide levels. And we have already seen the AA gradient. Now you can calculate the normal AA gradient, AH by 10 by 4. And you have to remember, whenever there is an increase in the FiO2, the AA gradient increases. So if you are using using 100% oxygen, if a patient is breathing 100% oxygen, your partial pressure in the alveoli increases to almost more than, the AA gradient increases almost more than 100 millimeter of mercury. Why this AA gradient is important? You have to differentiate whether the hypoxia is due to low atmospheric oxygen or alveolar hypoventilation, or due to any lung disease. Normally, the AA gradient is maintained in cases of alveolar hypoventilation and decrease in the oxygen tension at the atmosphere. But the AA gradient is increased in cases of lung diseases. So we all know the shunt equation, and we should understand the difference between VQ mismatch and shunt. Shunt is the complete deoxygenated blood which gets mixed with the oxygenated blood. So when there is an increase in the shunt fraction, and normally there is physiological shunt from the bronchial and Tabasian veins. And if there is an increase in the shunt fraction, how much ever you increase the FiO2, it's not going to improve your oxygenation. If you look at this picture, when there is a shunt, there is a complete cutoff of ventilation to this alveoli, and there is one part of the alveoli which has got good oxygenation. When this deoxygenated blood mixes with this oxygenated blood, the PaO2 decreases. So even if you increase the FiO2 to 100%, we are not going to improve the oxygen level at this alveoli which is not ventilated. So again, we are not getting a much increase in the oxygen tension at the arterial side. But in case of VQ mismatch, if you increase the FiO2 from 21% to 100%, definitely you can improve the oxygenation. That is one clinical point you have to keep in mind. So when you look at the oxygenation, always look for, when you are looking at the PaO2 of arterial ABG, always look at the PaO2 in context with the given FiO2 and try to calculate the AA difference to know where is the problem with the patient and calculate the shunt fraction to know whether increase in the FiO2 will improve the oxygenation or you have to go for recruitment maneuvers to improve the oxygenation. So if I show this ABG, the PO2 is more than 300. The patient has metabolic acidosis. We are not bothered about it at this moment. But it looks like the patient has good oxygenation. But if you see, the patient is getting 100% oxygen. So in a normal healthy lung, if you are giving 100% oxygen, you expect the PO2 around 500. So for a given FiO2, the PO2 is less than anticipated. So again, to show the heterogeneous lungs, how you can get there is an increase in the various contributing factors for hypoxia, where there is an increased dead space, or there is a decreased perfusion, or there is a VQ shunt where the deoxygenated blood is mixed with the oxygenated blood. So there are various factors which can cause impaired gas exchange. We all know the diffusion is by proportionate to the concentration gradient, and the amount of oxygen which diffuses into the at the capillary level depends on the area available for the diffusion and the pressure gradient between the two ends. So again, looking at the sample ABGs, in the first ABG, the PO2 is around 70. In the second ABG, the PO2 is around 260 millimeter of mercury. But when you look at it at the first site, it will look, the second ABG, the oxygenation is good. It's a better oxygenated lung. The first patient has some hypoxic issues. But again, if you look at the context of the FiO2, both are almost same, less than 3. And the FPF ratio is less than 300. So in both the patients, they have some hypoxic issues. We have to further, at the clinical context, you have to look how to correct the hypoxia. So to sum up, whenever you are facing with oxygenation problem, there may be low VQ mismatch or VQ heterogeneity, and there is an increase in the shunt fraction or decrease in spared oxygen tension, or there is alveolar hypoventilation. Moving on to the next topic of type 2 respiratory failure, respiratory acidosis. We all know, again, majority of carbon dioxide is transported as bicarbonate, some as diffusion in plasma and some as minimal amount as carbamino compounds. When you are, most of the time, respiratory acidosis is very obvious when you look at the ABG. If you look at the 3 ABGs, you can see the pH is on the acidotic both, almost on, all 3 ABGs almost similar pH, around 7.2, but the PCO2 values are totally different. The first ABG, the PCO2 is around 100. The other 2 ABGs is around 50 to 60. But the pH remains the same. So now the question is, we have to calculate whether there's a acute or a chronic process, because we expect more pH drop in the first ABG. So how to calculate whether, how to identify whether this is a this pH drop is appropriate to the amount of PCO2. So if you look at it, the bicarb is increased. We don't know whether this is the compensation for this PCO2 or whether it is a metabolic alkalosis. So if you calculate in acute respiratory acidosis, we expect the pH drop by 0.008 unit per 10 millimeter mercury of PCO2. So if you apply the same, you expect the pH in the first ABG less than 7. But in chronic respiratory acidosis, you expect the pH drop to be 0.03 units. So if you apply the same formula in the first ABG, you can see this is the acute and chronic respiratory acidosis. In the second and third ABG, it is acute respiratory acidosis. So in case of acute respiratory acidosis, always look for the causes, like whether the patient has CNS depression or any drugs acting on it, or the patient is a acute exacerbation of any acute lung problem or inappropriate ventilator settings and other things. So again, I'm just showing this ABG to make you people aware of inappropriate PCO2 response. Given the pH of 7.07, this is a severe acidosis, and with a low bicarb, we can safely say this is a metabolic acidosis. But in this patient, we cannot see any compensation at all. The same patient, after a few hours, the PCO2 has risen to 40. So this is an example of impending respiratory failure. You have to intervene and intubate and take a controlled ventilation of this patient. Otherwise, any further increase in PCO2 is going to drop the pH further, which will be catastrophic for the patient. So this is a relative hypercapnia in the setting of metabolic acidosis. So you have to intervene. You have to, though the PCO2 appears normal, you have to understand this is a sign of impending respiratory fatigue and respiratory failure. And broadly speaking, the causes for respiratory acidosis can be in the CNS, either due to disease or drugs or any human lesion affecting your neuromuscular ventilatory system, or any drugs which depress the central nervous system, or COPD, or severe OSA, which is increasing in our population. Of late, we are seeing a lot of patients with a severe OSA undiagnosed, and sometimes in case of upper airway obstruction where there is limited airflow. As we have already seen in the alveolar gas equation, when you are facing with hypoxia, look at the PaCO2. Most of the time, because of the highly diffusible nature of carbon dioxide, most of the time the alveolar partial pressure of carbon dioxide will reflect the arterial carbon dioxide. So if there is an increase in the arterial side of carbon dioxide, you expect the same at the alveolar side. Any increase in the alveolar CO2 will further decrease your partial pressure of oxygen. So you have to hyperventilate the patient to remove the carbon dioxide to increase the oxygenation. So remember that when you are dealing with a hypercapnic patient. Hypercapnic and at the same time, hypoxic patient. Again, this patient to show the metabolic acidosis with increasing PCO2, probably because of inappropriate ventilator setting. So even in a metabolic acidosis patient, when you have controlled ventilation, we have to kind of hyperventilate the patient to keep the PCO2 at the tolerable level till we address the primary acid-base disorder. What is called the cause behind the acid-base disorder? Why we are worried about the CO2? At the long run, the increase, the hypercapnia attenuates the phagocytosis. Though its anti-inflammatory effects attenuate lung injury, but it predisposes to infection, and it imparts the fluid transfer, which increases the interstitial space fluid, which increases the distance for diffusion of both oxygen and carbon dioxide. And most of the time in the critical care or in the emergency setting, when you are going to intubate or take care of the hypercapnic patients, you have to remember the sympathetic nervous system is activated because of the hypercapnia, and it causes pulmonary vasoconstriction, which increases the pulmonary vascular resistance, but the effect is less than we anticipate with hypoxia, and it shifts the ODC curve to the right because of the acidosis. And most important, on the cardiac system, it has depressant effects on the myocardium, and because of the vasodilation, it decreases the sphere, because most of the hypercapnic patients, you see, they have warm peripheries and flushed appearance. Why this point is important? Whenever you sedate the patient for intubation in a hypercapnic patient, whenever you try to sedate, how much minimal sedation you tend to use, it further causes myocardial depression and further vasodilates. The patient may have profound hypotension. You have to be ready to deal with those things when you plan for emergency intubation of hypercapnic patient. And because of the narcotic effect of CO2, the patient may present with headache and metabolic flap seizures and eventually unconsciousness. And we have already talked about the permissive hypercapnia in the previous topics. it is we deliberately we don't induce hypercapnia in ARDS patients. It's because we are trying to limit the plateau pressure and the driving pressure. We are not able to wash out the carbon dioxide, and it increases because of the increase in the alveolar dead space and the VQ mismatch. Now the bigger question is whether the permissive hypercapnia is beneficial, because there are contradictory reports in literature. Again, as I have said, that we are not deliberately inducing hypercapnia because we are not able to wash out the CO2. We have to allow the carbon dioxide to rise, but avoid PaCO2 more than 50 millimeter of mercury, and do not allow the pH rise above, below 7.25. So most of the time we think respiratory alkalosis is a benign disorder, but it is not as benign as we think or as we presume. We all know in respiratory alkalosis there is a decrease in the PCO2, and it inhibits carbonic anhydrase, which decreases the hydrogen ion secretion, which further it decreases bicarb reabsorption. It can present as a standalone in panic patients with pain, anxiety, or panic attack, or it can be a compensatory compensatory disorder for metabolic acidosis. Sometimes it can present with mixed acid-base disorders. Most common cause for respiratory alkalosis, other than your benign causes like pain, anxiety, and panic attacks, it is the hypoxia which causes hyperventilation. So as we have seen in the alveolar equation, when you hyperventilate, when you wash out the carbon dioxide, more oxygen gets in. So one way of dealing with hypoxia, the body's compensatory mechanism, is hyperventilating by washing out your carbon dioxide. And other causes can be pulmonary edema, sepsis, in cirrhosis liver, or sometimes iatrogenic when you use inappropriate mechanical ventilatory settings, and pregnancy, which increases the tidal volume and causes respiratory alkalosis, and sometimes hypothermia and hypermetabolic states like thyrotoxicosis, and drugs like hypothermia, drugs like salicylates, catecholamines, and your progesterone, and etc. So again, just to show you an example of how hypoxia can cause respiratory alkalosis in this patient. And similarly, with the metabolic, it's a combination of metabolic acidosis with as a compensatory mechanism, there is a drop in PCO2. But do not always look as respiratory alkalosis as a standalone or a benign condition or as a compensatory mechanism. There are sometimes some red flags, like do not miss the diagnosis of pulmonary embolism, pulmonary edema, or pneumothorax when you see a ABG with respiratory alkalosis. Rule out these red flags before you think it is something else. And sometimes most of our ICU patients are not straightforward patients. We may not get a simple acid-base disorder whenever you order for an ABG. Most of the time, your chronic respiratory acidosis patients present with metabolic alkalosis, because of most of the type 2 respiratory failure patients eventually develop carpulmonale. They will be on diuretic therapy. So there will be some component of metabolic alkalosis. So always use a stepwise approach and look at the degree of compensation and appropriate pH drop, and then you may identify a component of metabolic alkalosis, especially in type 2 respiratory failure, who will be eventually on diuretic therapy and steroid therapy for their lung issues. And sometimes you have a metabolic acidosis coexisting with respiratory alkalosis, especially in patients with salicylate overdose and sepsis with renal failure. This is actually interesting. Most of the time, we may not be able to differentiate whether the acidosis is due to renal failure or because of sepsis and hypotension. And sometimes in the ARDS patients, you see the respiratory acidosis and metabolic acidosis coexisting, and cardiac arrest patient, when you get a rhythm back and when the circulation started, when you do an ABG, the respiratory acidosis, when both acidosis will coexist. And sometimes interestingly, when you mechanically ventilate the chronic respiratory acidosis patients in the ICU, overventilation of type 2 respiratory failure patients will wash out their carbon dioxide, and you have a respiratory alkalosis and metabolic alkalosis component in a chronic respiratory acidotic patients. And sometimes we may get sampling errors. It's very difficult when you have a error in sample to interpret the ABG. The most common mistake is delay in analysis. You take a ABG sample and keep it at the room temperature, and there is a few hours of delay in analyzing. You expect the PO2 to drop and PCO2 to rise. Similarly, when they take a arterial sample, if they mix it with air bubble is present, again, the PO2 and PCO2 changes. And most of the time, we do not have the luxury of pre-heparinized syringe. We take heparin and try to coat the wall of the syringe with heparin and flush it out. But sometimes nursing staff, for the fear of clotting, they take too much heparin, which may make the sample more acidic. And it is very difficult sometimes in patients to differentiate the venous and the arterial sample. When there is a difference between the SpO2 and the SaO2 in the ABG, when there is a huge difference, you can straight away say this, that might be a venous sample. But when the difference is little, or when there are situations like low oxygen extraction situations like sepsis or some cytotoxic, histotoxic hypoxia, it is difficult to say this is a venous sample. So beware of these sampling errors when you are interpreting a ABG, especially with air bubble and delay in analysis. There will be difference in your PO2 and PCO2. Thank you, everyone.
Thanks all the 85 participants staying so far of 140 registered. So today we end the day here, and tomorrow we have a topic to start with. We have intubated the patient, how to go about ventilation, and it would be like HFNC, NIV, and invasive modes of ventilation. And I will put up the agenda by tomorrow morning. There's a slight change of speakers involved in this program due to the ISCC ongoing elections. So 2 speakers, due to their election rules, they are not able to participate. Dr. M. N. Shivakumar sir from Royal Care and Dr. Didipa Devaprasad sir from Apollo. Instead, we have 2 other eminent speakers who could share their knowledge here. I'll put up the update tomorrow. And that's for the day. Thanks again. Tomorrow we'll start the session sharp 7 p.m. like today. And hopefully we will stick on to typings tomorrow and finish early by 9 p.m. Thanks. And if you have any queries, feel free to post in the delegates group. It will be answered then and there. Thank you.